morning. My name is Pat Borgen. I'm the chairman of the Department of Surgery here at Maimonides Medical Center. On behalf of Ken Gibbs, our president, we'll be making some remarks at the end of the program. I want to welcome you to the 19th Annual Cardiac Symposium. The melodramatic music that you hear is on purpose. And I'm going to start with about 8 photographs, which I think will be a great prelude to an incredible video that Dr. Ribakov will be sharing with you. So, you have the house lights down. This is the recipient of the first heart transplant in the United States, second in the world, second by less than 72 hours. Done exactly 50 years and 1 day ago. This is the donor heart. This is Dr. Adrian Kantrowitz, who you'll be hearing a lot about this morning. And imagine what's going through his mind years ago on K6, which is where the operating theaters were. Imagine what was going through his mind as he prepared for this historic and dangerous operation. This was a tiny operating theater by any standards. Look how crowded this is. Today, things are quite different. Again, Dr. Kantrowitz. Actual photo from above the operating table. And worry and frustration, this photo probably says more than all the others combined about what goes through the mind of a cardiac surgeon at a time like this. But we're not here in a negative way, but to celebrate this event and to understand that what we do today is done because we're standing on the shoulders of giants. And you're going to hear about the history here at Maimonides and other places, and you'll hear about the continuation of excellence in cardiology and cardiac surgery that has really defined this institution for more than 100 years. This is, on the right, is Christian Barnard, who traveled around the United States learning whatever he could and stealing as many ideas as he could. And I have to believe in this photo that Dr. Kantrowitz might not have been deeply in love with Dr. Barnard. Less than a week after this historic event, Helen Taussig, the pediatrician / cardiologist, partnered with Alfred Blalock on the now eponymous Blalock-Taussig operation, wrote an extremely negative article in the Journal of the AMA saying that Kantrowitz was grandstanding and that the whole thing was a press event and that it went badly and they never should have done it. This was a scathing article. Following this, she wrote this letter that you see on the screen, basically saying, I hope I wasn't too tough on you with my criticism, but I was right. Now, she was 14 years after the first Blalock-Taussig shunt. She was a thought leader in cardiology and a respected voice. She could send a letter to the New England Journal and have it published the same day. And so this was devastating to Kantrowitz that someone of her position would be so offended by years and years and years of hard work and heroics. He wrote the nicest 5-page letter back to Dr. Taussig explaining the history and the animal work and describing the 2 babies as doomed and that they didn't have a choice and that they were going to lose both babies. And then she wrote a second letter back saying, okay, but I'm still right. So this really was the work of giants. Unfortunately for Dr. Kantrowitz, so this is the reference for her letter to JAMA, which was so scathing. And about 6 weeks later, Dr. Kantrowitz published another seminal work on intra-aortic balloon pumping in the same journal in the same year, about 7 weeks later, which unfortunately was overshadowed to a large degree by the work with, by the controversy over cardiac transplantation. So I'm going to switch gears very, very briefly for 2 seconds, because Chopin has also been in the news lately, and in the beginning of 2017, Chopin's heart was in the news, and I don't know whether you saw this or not. He needs no introduction. What's interesting about Frédéric Chopin, however, who died at age 39, was that he had a torturous love life. His romantic life was always in chaos. But what's interesting is that the more heartbroken he was, the more music he produced. And you can actually graph compositions per year against what he wrote about the foibles of his heart and of his love life. Linear relationship. There are a lot of paintings of his deathbed. If you add all the paintings together, there were 9,000 people at his bedside when he died. But the most important person was his sister, Ludwinka, in this painting by Kwiatkowski, who actually, on the far right, that's the artist. He painted himself into the death scene. Why not? But on his deathbed, Chopin had a fear of being buried alive. And so he asked his sister to do 2 things. Number 1, he asked her to have them remove his heart, and he asked her to smuggle it from Paris, where he died, back to his beloved home in Warsaw, Poland. And so she did that. So when he passed away, there was there was a death mask made, and there was also a cast taken of his left hand. Both of those can be seen today. But his heart was removed, and his sister, Ludwinka, smuggled the heart from Paris to Warsaw, where it was placed into the Church of the Holy Cross. So his body is interred in Père Lachaise Cemetery in Paris, along with a lot of other luminaries. But his heart is in Poland, in Warsaw, in the Church of the Holy Cross, in a column, in a support column behind this plaque. When World War II broke out, someone was smart enough to say, this is an iconic symbol of Warsaw, and the heart was removed from the church and it was hidden. It's not clear who rescued the heart, but a German officer named Boxalewski brought the heart back. Now, he was also known for war crimes, and he had a very tough history in terms of what he did to Warsaw. And so skeptics doubt that the heart that he returned was actually Chopin's heart. And skeptics say, why would he bring back, wouldn't it be cool for him to switch somebody else's heart and put it in Chopin's tomb? This is interesting. Here they are bringing the heart back to the Church of the Holy Cross. So there's been debate about what Chopin died of. It was clear he had the symptoms of consumption. He had the symptoms of tuberculosis. But whether he died of a tuberculous pericarditis was unclear. On the evening of April 14, 2014, a committee of 13 credentialed people met at midnight at the Holy Cross Church in Warsaw and removed the stones in front of the jar containing cognac and Chopin's heart, or somebody's heart, and they took 1,000 high-resolution photographs. The conclusion of the team of experts was that it was a constrictive pericarditis and that the photographs bore that out. But the government would not let them open the jar. No tissue samples were taken for genetic studies. And there are a lot of political reasons probably behind not wanting to prove whether or not this was Chopin's heart. Remember, one of the things he did was he gave locks of hair to his adoring fans. And so doing the genetics on the hair and the heart and the jar would have been pretty easy to do. And so it was not done. The jar was further sealed with wax. And this was published this year in the American Journal of Medicine in February of 2017. So for our residents in the room, does anyone know what famous heart surgeon this is? Dr. Leahy, what famous heart surgeon is this? This is a tough one. You have to sort of suspend gender biases here. This is Michael Debakey, the childhood photo of Mike Debakey. How about this one? That is Adrian Kantrowitz. And so the musical history of our institution and our department continues in a very deep way. So the musical roots between Dr. Rybakov and Dr. Kantrowitz are clear. They would have been a really cool band, right, Harry? Imagine if these two guys... Now, since this event, here's Greg last week at my house, lost the blonde hair, unfortunately. But so we have a lot to be proud of at this institution, and the fact that we are celebrating a half-century milestone could not be done in a better way than with today's conference. I'm delighted that the room is packed. It's appropriate. We have a stellar faculty. We have a fascinating program. I want to welcome you. And with that, I'm going to ask Dr. Jacob Shani to come forward to make some further introductory remarks. Jacob?
Thank you all for coming, and really welcome to our annual conference. And I want to thank the speakers again for coming from far away and share their knowledge with us. And I also want to welcome, we have a special guest today, the Health Commissioner of the State of New York, Dr. Zucker, is with us, and I'll let him address you in 2 minutes. But what we are celebrating today is, of course, 50 years to the heart transplantation here at Maimonides, and in my mind, maybe even a bigger achievement. The intra-aortic balloon pump was invented and developed and implanted first here at Maimonides, which is a device still being used and saving probably hundreds of thousands, not millions of people around the world over the years. So we are celebrating really advances in cardiovascular medicine, going from the past into today and into the future. And I can't let you go away. We have a big crowd here without a short commercial message. So excellence was always here when it comes to cardiovascular medicine, and it continues. And as you can see from the latest state report, we are the only institution in the state that is still statistically significantly better than the rest of the state. And when it comes to emergency procedures, we are the only ones in the state that is statistically significantly better than the rest of the state with the lowest risk-adjusted mortality. So excellence still continues at Maimonides, and this is my commercial message. There is no reason to go anywhere else. So I will shut up here. Thank you all for coming, and with that, I would like to introduce the Health Commissioner of the state, Dr. Zucker. Thank you.
Good morning, and thank you for inviting me. I don't have any formal remarks. I just actually wanted to say a couple words, is that this is primarily for those in training and for young faculty. you really should treasure what you're going to hear today and treasure the life and times of Dr. Kantrowitz and the fact that this took place here in this medical center. There's a large state and it's an enormous country and an unbelievable world that's out there and many hospitals, and to think that something took place right here in these walls 50 years ago, and you should really celebrate and take an opportunity to think about history and what happened. And I think that sometimes those in training forget that you stand on the shoulders of giants from before you, and they took on things that were very tough to do. And at that time, today we think about heart transplants is done, every day, all around the country, all around the world, and we just think it's second nature. But the fact is that Dr. Kantrowitz and his team sort of said, we're going to do something really novel, really changing medical breakthrough that in the same way that we talk about CRISPR therapies today and CAR T therapies and all those things, this was the same kind of vision that a scientist, a surgeon had at that time to do this. And I think you should really, after listening to the lectures, and I hear there are going to be some great videos, just think about it and leave thinking about the fact that it happened right here and that you're part of it and you're part of the legacy of the medical center. So I'm going to let those who are going to give the lectures, and I look forward to hearing them. Thank you very much.
Good morning. Hoping this works. Okay. So I'm going to repeat some things you've heard, and but as you all now know, 50 years ago yesterday, the first human heart transplant in the United States was performed right here at Maimonides Medical Center in Brooklyn by Dr. Adrian Kantrowitz. So his daughter Nikki is here today and should be acknowledged. She's, by the way, an excellent cardiologist here in Brooklyn on her own right. And 4 days before that, the transplant was performed in South Africa by Christian Barnard, and he did this in advance of both Dr. Kantrowitz and Dr. Shumway, who had really done the work leading up to a heart transplant being done. And not only did he scoop them using their own information, having spoken to both of them, having visited them, but then he largely took credit for the work. It's really sort of highly questionable in my mind exactly what his place was in the annals of having done in the history of heart transplantation. So, quoting from Sandeep Jauhar of the New York Times, and I'm quoting now, "The heart, heavy as it is with symbolism, has always occupied a special place in our collective imagination. Despite our relatively sophisticated biomedical understanding of its function, many people still think of the heart as the seat of affection and courage. When Barney Clark, a retired dentist, received the world's first permanent mechanical heart in 1982, his wife worried that he might not be able to love her anymore." Interesting what our thoughts are about the heart. And everybody should understand sort of what the greatness was of these people that led to this first heart transplant and now to what we consider to be almost routine. And nobody should underestimate the work that was done by all of these people. You've seen, this is Dr. Kantrowitz with one of the many dog hearts that he did, and you've heard a lot about this already. He performed the first heart transplant. He actually put one of the first Vads, and he was the inventor of the intra-aortic balloon pump. I think in a lot of ways, more significantly, he had $3 million back in the 1960s of federal grants to study this. It was the second largest grant in the United States for medical research, behind Michael Debakey at the time. And right here at Maimonides Medical Center. Something, by the way, that is very difficult to do in today's day and age, because people in a position of giving money out have stopped judging the ideas on their own merit and have begun to judge them on where they're coming from. And so it's very difficult for people in institutions like ours, even when they have really good ideas, to get the kinds of grants that lead to this kind of thing. And I think, unfortunately, that actually slows down medical research. So I'm going to show you, and I don't know if we can lower the lights or not, but this is Dr. Kantrowitz's presentation in 1968 to the American College of Surgeons, which most of this was filmed in 1964, of course, when the work was being done leading up to these transplants.
Our experiment is an attempt to develop a practical technique for transplantation of the heart in puppies under profound hypothermia, thus avoiding the use of a pump oxygenator. The recipient on the right is cooled to about 16 degrees centigrade, and the donor on the left is cooled to about 28 degrees. The ECG and blood pressure of the recipient are continuously monitored. Here is the recipient in the cooling bath. The chest is opened at the level of the fourth intercostal space, transecting the sternum. Tourniquets are applied here to the superior vena cava and the inferior vena cava. Note the very slow beat of the heart under this degree of hypothermia. A clamp is placed through the transverse sinus, occluding the pulmonary artery and the aorta. Then both of these vessels are transected. The right atrium is cut close to the ventricle, leaving a generous margin. The left atrium and the atrial septum are then transected, removing the heart. Note the removed heart with the slow ventricular fibrillation. Here are the aorta, pulmonary artery, right atrium, atrial septum, left atrium, and again, left atrial wall. The donor heart is removed by another team and kept in cold Tyrode solution until the recipient has been prepared. Two stay sutures are affixed in the superior and inferior aspect of the atrial septum of the donor heart. Here, the superior fixation suture is placed into the superior aspect of the recipient atrial septum. Now, the inferior stay suture in the atrial septum. Starting at the superior aspect, the right atrial margins are approximated. To make a watertight seal and to traumatize the tissues as little as possible. Here is the completed right atrial suture line. Next, the atrial septum is anastomosed, starting at the inferior aspect. The left atrial wall is repaired. Here is this completed suture line. The aorta is then anastomosed in routine fashion using a continuous everting suture. Before final closure, the left ventricle is flushed with cold thyroid solution to remove all air. Finally, the pulmonary artery is anastomosed. Here then are all the suture lines completed. The dog has been in complete arrest for about 45 minutes. The superior vena cava and inferior vena cava tourniquets are now released, and the clamp removed from the pulmonary artery and aorta. Circulation is restored with gentle cardiac massage. Simultaneously, the dog is placed in warm water and the chest cavity filled with warm saline. Calcium chloride is injected to increase the vigor of the ventricular fibrillation. Here one can see the coarse ventricular fibrillation. One shock reverts the heart to regular rhythm. At first, there is a 2-to-1 block, but this quickly changes over to regular sinus rhythm. Here are 3 puppies with transplanted hearts. It is the 42nd day for the brown long-haired terrier, the 3rd day for the lighter short-haired terrier, and the 20th day for the black German Shepherd. The same shepherd after 61 days. Note her growth and development. On the 92nd day, she plays actively with a 10-day heart transplant puppy. No immunosuppressive drugs have been used in any of these experimental animals.
How amazing is that? So this is Dr. Norm Shumway. I was lucky enough to spend a year working with him in the early 1990s at Stanford. Dr. Richard Lauer, who was his partner at Stanford and then later went on to, I think, University of Virginia or, yes, University of Virginia. And interesting story about him was, and there were various probes at different times that occurred back then. The reason that Christian Barnard was able to scoop everybody was that the laws of the United States, there were no brain death laws at that time. And so in order to be dead in the United States, your heart had to be stopped. And that was a major issue in terms of being able to then take a stopped heart and use it as to transplant. And in South Africa, they didn't have the same set of laws. And so he was able to get a donor heart earlier. As a matter of fact, the first heart transplant in the world would have been done here at Maimonides, was actually on the table to be transplanted prior to the one in South Africa. And I don't want to blame my anesthesia colleagues who are my good friends now, but back then, the anesthesiologist would not allow them to transplant the heart from an anencephalic baby until the heart stopped. And when the heart stopped, it was already too late for the transplant to occur. So the very first worldwide heart transplant would have happened here if not for that. But Richard Lauer was interesting. I mean, he and Shumway did a huge amount of work together in the labs at Stanford. And he's another guy who's less well known, except for those who really know about the history of heart transplant. But after he did his first heart transplant, he was actually arrested for murder. And for the next 2 years, he spent his life, he did not operate, he didn't do anything. He had to defend himself from a murder accusation, essentially, over this heart transplant. And he was eventually exonerated. And as a matter of fact, as a result of this trial, the brain death laws in the United States changed so that you could actually determine that somebody was dead prior to their heart stopping. And this sort of led to big advancements in transplantation, especially of the heart and lungs. So, we've already talked about most of this. This is the famous picture of Dr. Kantrowitz, Debakey, and Barnard. And he became, Dr. Christian Barnard, as a result of having done the first, became literally a rock star in the world. And this is the picture of the first person who had his heart transplanted in South Africa. There's a very fascinating story of what led up to that. But not long after this, on the cover of Life magazine is the tragic record of heart transplantation. And that's because over the next several years, the few heart transplants that got done, very few of them lasted very long. And it really looked like this was not going to be what some in the media thought it was going to be. And I have to say that Dr. Norm Shumway, who continued his work at Stanford through all the bad press and through all the tough times, and then figuring out really how to not solve, because we still haven't solved immunosuppression completely, but to get to the point where immunosuppression was actually good enough to make these heart transplants last, really deserves the credit for bringing heart transplantation into the world as it's known today. And I think without his work at Stanford, that wouldn't have happened. So there's so much more to the history of heart transplantation that we could talk about. Bruce Wright, who was also at Stanford, who did the first lung transplant and heart-lung transplant. But if any of you are interested, all of these books are histories of heart and heart transplant in medicine that are worth reviewing and seeing to learn all about this. So it's my honor to introduce Dr. Brian Lima. He is going to actually start us going forward with our actual symposium now. He's a really nice guy. He did his medical school at Duke and also his general surgery at Duke. He then went to the Cleveland Clinic for cardiac fellowship and heart transplantation. He was the attending and the director of the mechanical circulatory support program at Valvular until Northwell was lucky enough to hire him as their first director of heart transplant and associate professor of surgery. So, Brian, thank you very much.
Thank you, Greg, for that kind introduction. I kind of wish I went first. That video by Dr. Kantrowitz is a tough act to follow, so I'll do what I can. So in an hour, I'm going to try to summarize for everybody here sort of the current state of affairs in heart transplant and where things are headed. We've kind of gone through a lot of the history already. The classic Time magazine cover article. My favorite is the quote that you read about where Dr. Barnard is quoted as saying, "On Saturday, I was a surgeon in South Africa, very little known. On Monday, I was world renowned," which kind of speaks a little bit to some of the character flaws maybe that were brought up. And then, of course, the whole reason that we're here 3 days later, on December 6, 1967, the historic event that really was monumental in medical history that occurred right here. So Dr. Shumway then, this was sort of a flurry of transplants very quickly in the first few months around the same time. And then as Dr. Rubikov mentioned, Shumway's group really did take the step towards figuring out a lot of things that are critical to current heart transplantation, such as endomyocardial biopsies, the use of cyclosporin, heart-lung transplantation, et cetera. So, you know, the brief walk down memory lane, now we kind of delve into the current state and where we're headed. So I'm going to talk about the scope of heart failure, what the treatment options are, what some of the volumes and outcomes of heart transplant specifically are, techniques in surgery, which you've seen nicely there in the video. Not a lot has changed in 50 years. And some of the challenges that plague the field, really, the organ donor shortage and the issue of primary graft dysfunction, which I'll get into, and then some controversies / opportunities using hepatitis C positive donors, ex vivo, for quote-unquote heart-in-a-box perfusion, and donation after cardiac death, which is how the first couple of heart transplants were done, and now it's donation after brain death. So a lot of things to go over. It's no secret that we're in the midst of a heart failure epidemic. By 2030, in the U.S. alone, more than 8 million people will be impacted. If you kind of dig a little deeper into the numbers, within that realm of heart failure, there's about 300,000 patients in the United States that have advanced heart failure, meaning heart failure that would theoretically require either some form of cardiac replacement therapy, whether that's a mechanical pump or a heart transplant. That's a lot of people. Heart failure, does not get the same reputation in the lay public as far as being a very highly lethal disease. 1-year mortality with advanced, class 4 heart failure is on par with or worse than some of the, cancers that we think of as being very highly lethal. And the cost of care and the ends of life for advanced heart failure exceeds that of other commonly known chronic illnesses. So as far as heart transplants concerned, the outcomes keep getting better. The more we do, the more modern techniques, and currently we can quote patients a median survival of about 12 years, which is excellent. So really, after 50 years, heart transplant is still the gold standard therapy for advanced heart failure. And even, one controversial area is, what about patients over the age of 65? We just published a paper looking at that specifically, and really in appropriately selected patients over the age of 65, which is a cutoff at many centers, you can have reasonable outcomes as well, on par with controls. So the issue is that the number of heart transplants done in the U.S. specifically has remained relatively fixed, plus 2,500 or so a year. And we just, you don't have to be a mathematical whiz to do to understand that 2,500 heart transplants is a drop in the bucket when you're talking about possibly 300,000 people that could benefit from this therapy. So the other interesting thing to note is a lot of the heart transplants are done, the sort of the distribution of cases. There are many, many centers. I'd say the majority of centers do less than 20 a year, 10 to 20 a year. There are very, very few centers that do 50 plus a year. So that's a very so that expertise is kind of divided and diluted out. Where I was previously at Baylor, we were among, one of the top 2 busiest in the world in a very short period of time. But I think the dilution of experience is an issue too. Our volumes peaked in 2014 at 102, and then as we sort of revamped our mechanical circulatory support program, we sort of evened out to about 60 and 70, respectively. So I liken this period of time to the rise of the machines, left ventricular assist devices, to meet that need for all these patients that are dying from advanced heart failure. Left ventricular assist devices like the HeartMate 2 and total artificial heart for patients with advanced biventricular failure have really revolutionized the care of these people. You think about it, in 2006, which actually was the last time the donor heart allocation policy was revised, there's been an explosion in the number of LVAD implants throughout the world. This is, I think, like a 1,500% increase. I'd challenge you to find anything else in medicine that has had this explosion, maybe TAVR, in such a short period of time. It's so surprised that this was not predicted when they revised the allocation policy, and now there's issues associated with that. So here, we're actually going to have a new donor heart allocation policy be introduced next year. And with time, however, I would say that these pumps, outcomes have gotten better and better, just like everything else. More repetition, more experience, the devices are getting smaller, sleeker, less complications. So patients now implanted with these devices have survival rates that approach that of heart transplant, but aren't quite heart transplant. But unfortunately, these devices are not a panacea. They're not suitable for all cardiomyopathies. For LVAD specifically, you need to have univentricular, left-sided failure, and you need to have an appropriately sized chamber for this pump to fit. So you basically have your dilated cardiomyopathies, but for hypertrophs or restrictives, these really aren't situations where you can use an LVAD. So heart transplant still is critical for all these other subsets of patients. And as I mentioned, these mechanical pumps have definitely impacted heart transplant in that I would say the majority of heart transplants we do now, well over 50%, are in the setting of someone who's had a pump implanted. And I'll get into what the technical implications of that. Most of these are, left ventricular assist devices. You have a smattering of some ECMO, which we'll get into, total artificial hearts, RVADs. For patients that are bridged with these devices, the outcomes are reasonable, meaning on par with unbridged patients. You do see, though, that ECMO is kind of the outlier, and I think really that speaks a lot to some of the flaws in our allocation policy. These are really, really sick people, critically ill. They need a heart transplant yesterday. So, and because of our way our allocation policy works, that doesn't happen, and so I think that's why you see a lot of this. Heart transplant and mechanical circulatory support are intertwined on many, many levels. And we basically have a toolbox that serves a variety of purposes. And as a person that loves toys, this is great. This is a really fantastic field for any folks in training that are looking into the future. And these serve the function of, number one, stabilizing patients that are in hemodynamic extremis. Kind of get you a time to think about what the next move is going to be, recover end organ function, and then to determine, okay, is this person a bridge to a transplant? Are they an LVAD candidate? And as I mentioned, and you'll sort of hear me mention again and again, the new allocation policy is going to take into consideration these devices in a major, major, major way. And then obviously in patients that are transplanted that suffer primary graft dysfunction, these devices also function as a way of managing those patients. So getting into what some of these toys do and how they work and what outcomes are, ECMO is a big one, been around for a long time. Conventional femoral veno-arterial ECMO, the reperfusion cannula, you provide theoretically biventricular support. There's ease of insertion, can be done at the bedside, various cannulation configurations. The cons doesn't really reduce afterload. You have some limb complications and bleeding. As I mentioned, any high volume heart transplant MCS program, you're going to have a lot of ECMO, and our ECMO program at Baylor exploded. So, and this is just, and if you look at the breakdown, out of 400, 60% of these are veno-arterial ECMO, meaning patients that are bridged to something, either myocardial recovery, to a transplant, or to an LVAD. We're going to need to be more creative with cannulating people in a fashion that can promote mobility, not having them bedbound as they're sitting there waiting for their transplant. So axillary artery graft cannulation for ECMO is something that I think you're going to see a lot more of. We published from Cleveland Clinic the largest series in the literature of axillary veno-arterial ECMO, and the unique complication that you see in that setting is hyperperfusion of the upper extremity, which will require either restricting the outflow of the axillary or changing your cannulation site. But you will see a lot of this. This is one of our cases where we did veno-arterial ECMO in the axillary, artery and vein, and this guy we literally had him, and unfortunately I couldn't find the video, literally on an exercise bike with rocky music in the background, waiting for his heart transplant. So this is now, and this is definitely play a bigger role in the future. Some of the other toys at our disposal, the percutaneous vads that provide full support, such as the Impella 5 that has to be placed via axillary artery graft, the tandem heart, and you have now right-sided percutaneous devices like the Impella RP and the Protect Duo. The cons with these are that it's logistically much more difficult than ECMO. You got to have fluoro, you got to be in a cath lab, hybrid room, and you have to have some catheter skills. So not basically a flick of the switch and you get it done. So there is some challenges there. We published I think the largest experience with the Axillary 5 Impella as a bridge strategy to either transplant or LVAD. It was 40 patients. And what it allowed us to do is decipher candidacy, whether, if we weren't sure about the kidneys, do the kidneys come back when you simulate what full flow will be like with an LVAD? Do the right ventricle numbers get better? Is this something that is going to be manageable with just single ventricle support? We'll get into the surgical techniques. Again, the video really did it, most of it. A lot of it has not changed. I think some of the salient principles to keep in mind, we really are targeting a cold ischemic time, meaning out of the body time is of 4 hours. That's the lowest for any of the organs that are transplanted. So the clock is ticking in a big way, and you really have to coordinate your recipient and donor teams. So that's the central message. You also have to keep track of which one's the donor heart and which one's the recipient heart. And it's usually pretty easy to tell, but you just got to make sure you have that set up. Donor cardiectomy, the major principle there is you cannot have distension of the heart. You have to be sure you adequately vent the heart. That can be done in a number of ways. If there's procuring lung team, when you elbow them out of the way so that they stop interfering with how much left atrium you're going to get, you usually have to vent through the left atrial appendage. But if there is no lung being taken, you can with impunity just transect the pulmonary vein. So once the donor heart is out, that's when you do like your back table, look, make sure there's not anything, PFO that you need to fix, anything like that. Make sure there's nothing funny that was missed on all the echo that preceded you taking the heart. And, you ship it in an icebox and you're on your way. Meanwhile, back at the recipient hospital, we're trying to orchestrate the timing where you have this, meaning the recipient heart is out moments after the donor heart arrives into the room. That's the goal. So recipient cardiectomy proceeds more or less kind of like the donor cardiectomy. The difference is you're going straight at the right atrium, and there's usually a lot of hardware there that you have to remove. But at the end, you're left with a left atrial cuff. And as you saw in the video, that anastomosis was done with a right atrial cuff as opposed to an SVC and IVC anastomosis, or what we call bicable. The trend now, for a couple decades now, is to go bicable, and I'll explain why that is. The sequence of anastomoses are left atrial cuff first, followed by the inferior vena cava, the pulmonary artery, the aorta, clamp off, and then the SVC, beating heart. I like to give antegrade cardioplegia down the aorta in between each anastomosis, just conventional cardioplegia that you use for conventional cardiac surgery. And as I said, this is the bicable technique. You can alter the order here, so if you're running, close on time and you want to try to cut some corners, you can do the left atrial cuff and then the aorta, release the clamp, and do the other ones. The visibility and bleeding and things like that is a little more difficult, but doable. But that gives you another half hour that you can shave off the time. As I mentioned, it's really bicable how we do it these days, as opposed to initially in the heart transplant experience. The reason for that is many studies have shown that with bicable, you get less atrial arrhythmias, less TR, and overall just better survival. So as I mentioned, a lot of these patients coming in for heart transplant already have hardware pumps that have been implanted. And the whole transplant, what's going to make or break you on every transplant in those scenarios is how well things were left behind at the initial LVAD implant. Because if you have adhesions or an outflow graft that's tightly adherent to the sternum, you're in for a long night. So the guys at Cedars have really, the busiest heart transplant program in the world. They do about 125 a year. They've really paid a lot of attention and written a lot about how to tee things up for the subsequent transplant. They use a lot of Gore-Tex sheets to shield the critical structures, and they actually use a silastic membrane that they leave as they're crossing sternal wires. They leave it underneath the sternum, and on CT scan you can see this membrane there, and that's kind of as an additional barrier for when you're going in with your redo saw at the night of transplant. So ideally what you'd like when you have this case of an LVAD explant You do peripherally cannulate femoral or axillary and, venous in the femoral. And then, you have your nice Gore-Tex that, that shielded everything. And you get your SVC cannula in, and there you go. And the rest proceeds like as before with conventional transplant. Unfortunately, it's not always nice and neat in these scenarios, and your hand is forced to employ hypothermic circulatory arrest. I think this is the only series, to my knowledge, that we published last year. With this was actually 7 patients that required hypothermic circulatory arrest. It's not fun, but sometimes you have no choice. Sometimes you're dealing with a porcelain aorta or pseudoaneurysm of an infected outflow graft, infected biventricular assist devices. This is a patient that had multiple previous surgeries for tautology of Fallot and had a calcified pulmonary right ventricular outflow tract. Like I said, it's doable, not pleasant. Survival is, 1 out of 7 did not make it out of the hospital, but the morbidity is pretty substantial. Long hospital stay, kidney and respiratory issues. So getting on now to the challenges that plague heart transplant. And first and foremost, I would have to cite primary graft dysfunction or graft failure. It's gone by many names. It is still the leading cause of early death following heart transplantation. A lot has been written about it, but what was confusing matters for many years is there was no standardized definition of what primary graft dysfunction is. So thankfully in 2014, Kabashigawa from Cedars convened a group, and they basically came up with a consensus definition of primary graft dysfunction. It's defined within the first 24 hours, and it's based on echocardiographic and inotropic information, as well as the need for supportive mechanical pump. So to summarize, severe primary graft dysfunction means you're on ECMO, basically. Moderate is you're on rocket fuel, pressors and inotropes, plus minus a balloon pump. So we were the first to really look at this new definition and apply it to a modern data set to see, okay, how well is this in real practice? So we looked at our experience in 200 heart transplants, and what we found is based on this new definition, 70% had no degree of primary graft dysfunction. 18% mild, 4% moderate, and 8% had severe primary graft dysfunction. So all 8 these patients required ECMO post-transplant. Our overall 30-day mortality was 3%. All 6 deaths occurred in the severe primary graft dysfunction group. We had no deaths in the other forms of primary graft dysfunction. Our salvage rate with ECMO was 63%, which compared to the literature was favorable. The range has been 50 to 82% salvage rate with ECMO. But the real question is, how does that impact longer-term outcomes? We saw a pretty readily discernible impact on 1-year survival. None and mild, they kind of almost were collinear here, but moderate primary graft dysfunction had definite decreased 1-year survival, and severe primary graft dysfunction definitely had compromised long-term survival. For the purposes of statistical analysis, we combined the mild and none and moderate and severe to kind of get more information about what some of these risk factors are and what predictors are of primary graft dysfunction. Our model basically indicated that recipient creatinine, once you kind of hit more than 2, the risk of moderate or severe primary graft dysfunction went up. If you were hospitalized as a recipient, meaning you were sick, not being able to leave, ICU, intubated, et cetera, that also raised the risk. If you were undersized donor, and I'll get into that, and this specifically means if you undersize the donor by predicted heart mass, not weight, that also increased the risk, and if you combine all of them, the risk goes way up. Getting to size matching, this is very controversial. The official guidelines cite that you should really try to, sizing is based on weight. You should try not to undersize by 30%. But a lot of studies that performed using cardiac MRI really have shown that weight alone is not really the best predictor of cardiac size. You can have a male and a female, same age, same height, same weight, and the male could probably be 19% larger heart size than the female. So when you look at the equations that were derived from a lot of these cardiac MRI analyses, you can come up with a predicted heart mass calculation. And this study didn't really look at primary graft dysfunction, it just looked at overall outcomes. And it definitely showed that predicted heart mass was a good predictor of that. We sought out to look at how undersizing by predicted heart mass versus total body weight impacted primary graft dysfunction. We presented this at this year's ISHLT, and we basically were doing a comparison, undersizing by weight or undersizing by predicted heart mass by greater than 30%. We had 250 heart transplants, and of that, 15 and 18 developed moderate or severe primary graft dysfunction. So we went back and we looked at our cohort. If you undersized just by weight by greater than 30%, you really had no appreciable difference in the rate of moderate or severe primary graft dysfunction. However, when you undersized by predicted heart mass by greater than 30%, you had a statistically significant increase in the risk of primary graft dysfunction. So when our multivariate analysis, also donor undersized by greater than 30% was predicted. Our conclusion, therefore, and our recommendation is the manuscript under review by Journal of Heart and Lung Transplant, is that instead of using size, centers really should incorporate this predicted heart mass equation when we're deciphering the appropriate use of certain donors and how we size match. Another predictor of primary graft dysfunction that actually has been identified more recently, this is a great work out of the Columbia group, is recipient amiodarone exposure. So the risk of primary graft dysfunction goes up the greater the dose of amiodarone the patient's on the day of transplant. It also has to do with how much cumulative amiodarone dose they've received over 6 months, where it goes up a lot as well. I don't think it was underpowered to see a 4-year survival difference, but the trend is there. And so I think this is really actually changing practice, and a lot of centers now are moving towards trying to eliminate amiodarone in any patient on wait list to mitigate this risk. So, getting now onto the art of donor heart selection, it would be very, very nice if it was this easy. The issue really is that there's no such thing as a perfect heart. It's the right heart for the right patient at the right time. That's really the central theme. And I think, honestly, the shortage that we often throw out as a term is on some level self-imposed. And I think many people exercise overly stringent selection criteria and confuse risk factors with contraindications. Those are not the same thing. So one example is donor age. The old adage was, donors over the age of 50, just forget about it. You hear the call and you hang up the phone. I mean, you don't even let the person finish the description of this donor. We were an aggressive program. We decided to look at our donors that were over the age of 50. We had 30 of them. Importantly, what we saw was no difference whatsoever in the rate of primary graft dysfunction. So again, I think some of these myths need to be debunked, and I think in appropriately selected donors over the age of 50, you can use them, and there should not be an increased risk necessarily for primary graft dysfunction. Another one, and this is actually my favorite, is donor sequence number. So when a donor heart becomes available, they go down the list. So donor sequence number 1, and you offer it out, and a couple centers will say no, 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 and then one center will accept it. So donor sequence number 6. There's a lot of bias here. So if you get a call at 2 in the morning about a donor heart that's donor sequence number 55, your immediate gut instinct is, okay, so 54 other places or 54 other, this has been turned down 54 times. What's the catch? So you're immediately turned off. This is just human instinct. We want to really look at what impact DSN had on outcomes. So our idea, and others have also expressed this, is that some of these donor hearts are diamonds in the rough. That $5 bill on the sidewalk that everyone keeps walking by and think it's somebody else's, and then you're the guy that just picks it up and it's your $5. So we looked at our cohort, and we wanted to look at our spectrum of donor sequence number. We wanted to look at the greater than 75th percentile to see how those compared with our lower donor sequence numbers. And we wanted to apply a well-established tool known as the Donor Risk Index that calculates risk based on how far away, ischemic time of the heart, donor age, race mismatch, et cetera, and it's a point system. So our range went all the way up to almost 1,500 for donor sequence number. Our 75th percentile was 80. So 75% of our patients were 1 to 80, so we were very, very aggressive. So how did these patients do? So you had 50 patients with donor sequence number greater than 80. And obviously, these were hearts that were further away, so their ischemic time was statistically significantly greater, 4.5 hours versus 3.5. Look at the distance, 860 miles versus 324 miles. So it's Texas. Everything's big in Texas, so you go way out there. I've gone to San Francisco, Puerto Rico. I've flown here from Texas to get hearts, so all over. And the donor risk index obviously was also elevated in this group, 5.4 versus 4.4. No differences in outcomes. Equal survival and, importantly, equal rate of primary graft dysfunction. And on multivariate analysis, not a predictor of outcomes. So basically, don't be biased by the donor sequence number. There's not always a catch. Just pay attention to the story, look at it objectively, and then make a decision based on objective clinical criteria as if you were hearing it for the first time. So I was very honored to be a part of a committee at the recent American Society of Transplant conference where we spoke specifically for a number of hours on donor heart selection. And a couple of the myths that we collectively sought to debunk was, number one, oversizing of the donor is not necessary, even if you have pulmonary hypertension. Obviously, you don't want to undersize those. You don't necessarily need to oversize female into male. Size matching, as I alluded to, should include LV mass, not just height and weight. And if you have a young donor and a good graft function, that takes priority over everything else. I don't care if the ischemic time is 6 hours. I mean, that donor is pretty good. There is no, and this is a big one, no unacceptable length of CPR downtime if the echo is okay. A lot of people hear, how long was chest compressions for half an hour? Forget it, I'm done. But the echo's perfect. There are no inotropes. There are no pressors. What's wrong with that heart? So CPR for however long is not in and of itself a risk factor. You have to look at what the data tells you. And some of these patients, they're in a brain death state, neurogenic shock, so some of them are going to be on pressors and inotropes. That shouldn't automatically be a dismissal either. So what we've seen in the United States is a significant decline in donor heart utilization, 44% in 1995, down to 32% in 2010. And I hate to say it, and it's kind of the reason why I came back to New York. I'm from New Jersey, so it's like a homecoming for me. Is news to me was that Region 9, New York, has the lowest donor heart acceptance rate in the United States, looked in red here. If you look more closely at the numbers and regional differences in wait list time, again, here's Region 9 in this era of, since 2006, since this new allocation policy, 144 days wait list time. Look at all the other, we're the highest in the country. The only one closer is 113. So we're way out there. We're a big time outlier, which actually was what prompted these impending changes to the donor heart allocation policy. There's clearly some geographic heterogeneity in how transplant is done in the United States. So I don't have all the reasons for why that is, but I think this new allocation policy is a step in the right direction to help alleviate that. So our current system is, as far as level of urgency, 1A, 1B, and 2. This new system, which will take effect, I believe, June, hopefully, is going to split this out into 6 tiers, where what's 1A now, you're going to have 3 to 4 tiers of severity. More on this. So the national transplant rate, if you just kind of take the average, is 66.8%. Region 9, our region, is 43.6%. If we were to just say, let's level the playing field, this new allocation policy does what it's supposed to do, and we're all even, that's going to lead to 77, theoretically, 77 more transplants in our region in a year. That's a lot. That's a lot of transplants. Considering I think we only did 320 in this region. That's a huge increase. So this is what it looks like now, 1A, 1B, and 2, what the criteria are. The new system would be 1. So that's why I mentioned ECMO. The Tier 1, ECMO up to 14 days. So if you have someone on ECMO and you can demonstrate that they have no other out, they're going to be at the top of the list. And the second thing is that it's going to be a mandatory sharing within 500 miles. So heart becomes available at Hospital X. They're going to look for 500 miles around to look at all the tier 1s first, then move down to tier 2. That's not what happens now. So I really, really think this is going to make, level the playing field and be better for everybody. Lastly, I'll end with controversies. I hope I'm doing pretty good on time. Whenever we talk about risk-benefit, it's really the risk all for the patient, but it's our job to sort of educate them on why certain risks are worthwhile taking. So, huge opportunity and very controversial, the use of hepatitis C donors in hepatitis C negative recipients. We're basically 2 years, 3 years into a totally new era of hepatitis C. There's drugs now that have recently been FDA approved that achieve almost 100% cure rates for hepatitis C. Hepatitis C now is essentially like CMV. We cross CMV all the time in heart transplant. And CMV really isn't curative. Hepatitis C is actually curable now. So, for the sake of argument, if we look at the prevalence of hepatitis C in our population, and we look at our current heart donors and deceased liver donors, if we started to use hepatitis C positive donors, we could expand the donor pool by 3 to 6 times. That is massive. Before I left Baylor, we had a patient who, hepatitis C negative, on ECMO, intubated, multiple pressors, not a device candidate, who was literally dying. We approached her, and family offered the use of a hepatitis C positive donor. They said yes. We used a hepatitis C donor. We followed the viral levels very closely, and we saw that the virus became detectable by about day 12. We initiated the antiviral, and in a few days it was undetectable. A year out, there's no detectable hepatitis C. So Vanderbilt, for example, just presented at the HFSA, and they have 25 patients that they've employed this strategy. So something to think about. The heart in the box. So as many of you know, currently for a lot of the organs, heart definitely, we basically take the heart out and throw it in a bag in a cooler and bring it back. Very sophisticated stuff. So, and the clock starts ticking, 4 hours. This is basically a system where you take the heart out and put it on a perfusion apparatus and perfuse it with the own patient's blood, so it's basically being perfused. It's being done a lot of places. It's already being done for lung in the United States pretty extensively. But what it does is it allows you to increase that window of time out of the body. It allows you to look at hearts maybe that you're not so sure about. It also, as we'll get into, enables the use of DCD donors, very controversial, we'll get into that. The UK and Australia use this very aggressively, and have had much success with it. I'll show you a quick video.
From the donor's body, the heart is quickly connected to the device through the aorta.
You get the idea.
Seriously, just one of the most amazing things I've ever.
Here we go. First sort of publication on this technology is in Lancet in the Proceed 2. So the way, the sort of conduct of this type of technology is you take the heart out, and it takes about 30 minutes or so to get it all plugged in onto the system. Obviously, with time, you get more facile with it. And then you have this period of time of warm perfusion, and then you have to undo it, take it off the system, so you have this other time at the back end where you're actually sewing it in, et cetera. Compared to standard cold storage, obviously there's more out-of-body time, but looking at cold ischemic time, which is the really more important factor, it's much less with the OCS system. What you do while the heart is on this apparatus is you basically have control over coronary flow, heart rate, pharmacologically, and pacing, and aortic pressure. You can give pressors, and you're aggressively checking lactates. Lactates is what kind of gives you an indication of how well the heart is doing. Not surprisingly, in these normal brain-dead donors, your starting lactate is not so high, and your ending lactate is not so high. And you wouldn't expect it to be any different, which is not the case for DCD donors, which I'll get into. This has been studied a lot. Initial experience, no difference in early outcomes at 30 days. No difference in survival or rejection. A subset of this study was done at Cedars, and they looked at their group. There appeared to be a little lower survival in the OCS group. Didn't reach statistical significance. They're not really sure why that is, but this is more 2-year data. Where I really think this technology is game changer is in the setting of using DCD donors, donation after circulatory or cardiac death. The definition of that means it's a donor who has suffered a devastating brain injury and maybe near death, but does not meet formal brain death criteria. So in that setting, you would have to have the family consent to withdrawal of support, extubation. And then you're allowed to recover organs only after you've confirmed asystole for up to 30 minutes. So you basically have a dead patient. And there's also a 3 to 5 minute standoff period, meaning you withdraw support, extubate, let the A line go flat. Once it's flat, wait another 3 to 5 minutes, and then you can proceed with, this is done routinely now in the United States for liver, kidney, and lung. And Dr. Hussein, who's my partner that we brought from Cleveland Clinic, has extensive experience with doing DCD lung procurement. Where you do this withdrawal event is usually, it could be in the ICU, in pre-op holding, in the OR adjacent to the recipient OR, all kinds of configurations. As I mentioned, it's widely used for other organs. Where things have taken off with the ex vivo perfusion is in this setting, where you basically, in that patient that has cardiac death, take the heart out and immediately put it on this apparatus to resuscitate it. This strategy of using DCD donors has increased heart transplant volumes in the UK by up to 40%. This is some of the early studies of this technology. This gives you an idea. There's 3 donors, where the withdrawal happens, OR, ICU, anesthetic, pre-op holding, how long they wait before they can proceed, and the warm ischemic time. This is basically how long it takes them to open the chest and get the heart out. And then the different parameters that they use to modulate the heart, whether it's pacing, adrenaline infusion, et cetera. And what the starting lactate, so once the heart is out and you measure the lactate, these are elevated, 8, 6.8, 7.6. But by the end of the perfusion period on this apparatus, it's down to 2 where you want it. And these are the kind of numbers that you see. You see a steady coronary flow, you see steady heart rate and aortic pressure, somewhere in the 70s. And then these are the lactate values, arterial and venous lactate. Start out high, and then over the course of the perfusion period, get back down to where you want them. DCD donation is increasing in the United States. Obviously, not yet for heart. It's not yet done for heart. But you can see there's a trend towards increasing DCD donation. And this just was published in this issue of the Journal Heart Lung Transplant, looking at the UK's experience with DCD heart donors. And they compared it with standard heart donors, standard brain-dead donors. 1-year survival, exactly the same. No difference. So, huge opportunity here. Now, going way out into the future, like way into the future, like Star Trek future, there's movements afoot. David Sachs's lab back at Mass General had made a lot of strides in trying to employ xenotransplantation using pig hearts, getting genetically modified pigs so that you basically have a heart factory or an organ factory. There's a recent publication in Science where some scientists have figured out how to eliminate a certain pig virus that's endemic to pigs. So a lot of work still being done there. I think Dr. Shumway, his quote about xenotransplant was, xenotransplant is something for the future and always will be something in the future. So he wasn't a big believer in this. There's also finally the decellularized ghost hearts. You take a heart out, you decellularize it with detergent and leaving behind just a scaffold of connective tissue that is not immunogenic in any way. You populate it with stem cells and then you have a heart 3 days later. So this theoretically is something that could be possible as well. I'll end by saying the following. Heart failure is a global epidemic. Heart transplant is still a gold standard therapy, limited by the number of available hearts, and also impacted by the emergence of durable MCS modalities. And I think refinements in donor heart selection will continue to improve heart transplant outcomes. We'll see how this new allocation policy impacts these donation rates and overall geographic disparities. The heart-in-the-box technology, I think, is going to open the door to being able to use DCD heart transplantation. And I think also opening our minds to using hepatitis C positive hearts is also an enormous opportunity. And then we'll see what the future holds with xeno and ghost heart transplantation. Thank you very much.
Thank you so much. It was really a fascinating talk. And we will have a session of questions and answers at the very end. So we will proceed. And it gives me great pleasure to introduce to you now Dr. Andrew Eisenhower, who comes here for a second time. Dr. Eisenhower actually went to medical school here in New York in NYU, was an intern resident at Brigham and Women's in Boston, did his cardiology fellowship at the Mass General, and afterwards was an attending in the cardiac catheterization laboratory at Brigham and Women's Hospital for many years. A couple of years ago, he decided to actually do something that is more socially redeeming, and he moved to Central Maine Hospital in Maine, where he is the chair of the Department of Cardiology. Dr. Eisenhower is well published in the field of cardiac catheterization and structural heart disease, and he will talk to us about transcatheter valve interventions. So please welcome Dr. Eisenhower.
All right, so I have to get the slides up here. I feel a little bit like Elizabeth Taylor's seventh husband on their wedding night. I know what to do, I just have to make it interesting. Right, there you go. Don't even know my own password. Okay, that's great. So thank you very much for asking me here. As Jacob said, this is my second time, and I guess I just didn't get it right the first time. And so we're going to try this time. Disclosures, I have some relationship with Edwards Life Sciences, some grant support and some consulting. And I am going to talk a little bit about off-label devices. And yes, by the way, I've gotten a lot of nice pens over the years. So I told everyone that I was always going to try to be grateful in giving talks. And a little bit of background about how I got here. So some years ago, Mike Davidson, who's pictured here, and I started the transcatheter valve program at the Brigham. And many of you know that Mike was murdered by a patient of ours a couple of years ago. But I was thinking about this in giving this talk, that Mike is sort of a Kantrowitz sort of person, because he was a real Renaissance man. And you see in the middle, he's actually doing an echocardiogram. He's the only cardiac surgeon in recorded history to have done an echocardiogram. And he's in the bottom, he's asleep after a long night of saving lives. So Mike was a great friend of mine, and we started the transcatheter valve program. This in 2009, the Brigham. And so as Jacob said, that I left a couple years ago to go to Maine, sort of the way life should be. Get out of the Boston area up to Central Maine Medical Center. That little dot of red is Lewiston. You can see there's 3 other dots in the state where there are medical centers that do heart surgery. At Central Maine, we have a very, very large catchment area. The dark green is where population density is 10 persons per square mile or less. So in order to treat patients in this area with high technology medicine, you need a helicopter, which sits outside my office, and you need a team. This is our team of the structural heart service with cardiac anesthesia, and myself, and Paul Weldner, who is our structural heart surgeon. So it's been a very interesting journey to start a transcatheter program in a large academic medical center, and to start one in what is essentially a community hospital. But I want to take this back a little bit, and I was a history major in college, and so you're going to be stuck with a little history. So Bill Roth, who many of you know was one of the deans of surgery in Europe in the 1800s, said the surgeon who would attempt to suture a wound of the heart should lose the respect of his colleagues. And the heart, of course, was off limits, almost to touch. Right? You couldn't catheterize the heart. Forsman in 1929 catheterized himself. It was thought that if you put a catheter in the heart, you'd have fibrillation immediately and patients would die. It was almost a sort of religious thing. But disruption and innovation has always been a part of medicine. And this was a few months before the first heart transplant. Does anybody know what this is? Good. This is Stockholm, Sweden on that date, when they went from driving on the left side of the road to driving on the right side of the road in a single day. And you can see the disruption that happened there. But why did they do this? Was it just a lark? Well, no. Of course, there were very few countries in Europe, except for the Brits, that drove on the left. And so they thought, gee, we have a large auto industry, we have Saab, we have Volvo, we have things we want to sell in the rest of Europe. We're a small country. Our neighbors drive on the right. We should drive on the right. And they made this disruptive but forward-looking decision. So similarly, for heart transplantation, it was a disruptive but forward-looking technology. It required a lot of thought, a lot of research, but a lot of understanding of what had gone before. And this is the scene that you've seen several slides ago. So starting back in 1923, and there'll be a little bit of Boston, this Elliott Carr Cutler, who was a surgeon at Brigham, decided that he would treat mitral stenosis. And this was his patient. This was published in the Boston Medical and Surgical Journal, which is the forerunner of the New England Journal. This is easily available online, and I suggest anybody interested in cardiology or cardiac surgery read this paper. But this is a young girl who had very severe mitral stenosis. He did a closed mitral commissurotomy, and she survived. Cutler was in the military, and his protege, Dwight Harkin, also became a military surgeon, as many people did in Boston, in the Second World War. And when you were a military surgeon in the European theater in the Second World War, you saw a lot of chest injuries, as Harkin did. And so he recognized that many of these chest injuries, penetrating injuries to the heart, were fatal, and he would try to do things to salvage these patients. And so he had a lot of kind of, I guess what you'd call almost animal lab experience in this kind of situation. He knew Cutler, he knew Cutler's work, and when he got back, he said, we can do closed mitral commissurotomy, which he did. He invented these instruments to do a closed mitral commissurotomy. Interestingly enough, he didn't have very good results. So if you look at six of his first 10 patients died. And he was about to give this up, and his colleagues convinced him to go ahead, to look at what he'd done with his results, to look at what happened. And remember, in those days, that severe mitral stenosis was a death sentence. It was as much of a death sentence as heart failure because it would result in heart failure. And there was no medical treatment that was useful. So Harkin persisted, but it was recognized then that you could actually operate on the heart. But this was beating heart surgery, right? In the 40s and 50s, Blaylock, Taussig, Vivian Thomas, shunts for tetralogy of Fallot, but still beating heart extracardiac surgery. Gross and Crawford did coarctation repairs in the 40s, again, around the heart, beating heart surgery. Despite the work of Harkin, maybe because of it, ASDs were thought to be the only congenital intracardiac defect that could be tackled, because you could actually physically get into the atria without stopping the heart. You could do this on a beating heart. VSDs, AV canals, tetralogy of Fallot, other things that we do routinely today were thought to be impossible. Again, almost like a religious prohibition. But the inner sanctum was broken into, and this is Gibbon, who was at the MGH, and he had been there for a long time. And of course, the MGH takes credit for everything, so it decided that, you know, the heart-lung machine was invented there, but he invented basically the heart-lung machine. He had a number of patents. He had a very, very aggressive research effort, and this is his first device, which used a membrane oxygenator of his design. Very cumbersome, very expensive, lots of piping. And he went on to Philadelphia. He tried this machine. His first operation was on a 15-month-old. She may have had an ASD. Remember, the diagnosis of congenital heart disease back then was stethoscope, common knowledge, chest x-ray, not much else. So many patients who were thought to have a VSD or an ASD may have had more complex congenital heart disease, and you didn't really make the diagnosis until you actually saw the heart. And so this patient may have had the wrong diagnosis. 18-year-old is the next case. ASD treatment, 26 minutes, died. Next two 5-year-old girls, ASDs, died. He never operated with his machine again. Great idea, but not quite enough. Clarence Dennis treated a 5-year-old on the heart-lung machine. There were 16 people in this very small room. It was a wrong diagnosis, and it was a bloodbath, and this young woman died. Cheryl Judge, a 2-year-old with an ASD, correct diagnosis eventually, but the pump lost prime. She had massive air emboli and also died. So not an auspicious beginning for cardiopulmonary bypass. So folks thought, gee, this is not the pathway we should be going down. What about hypothermia? This is Napoleon's retreat from Moscow. And so since the time of armed conflict, people knew a lot about hypothermia, and it was recognized that when you were hypothermic, the body's processes slowed down, and you could actually be revived much more. Cold water drownings, things of that nature. And it could extend the ischemic brain time by cooling about 10 minutes or so. So you had to work very, very fast, and you still have to today with profound hypothermia. Bailey did a 32-year-old with an ASD, heart fibrillated. That patient died. John Lewis, University of Minnesota, did the first successful ASD closure in about 5.5 minutes of operating time. Right? A very, very difficult thing to do today. Lewis attempted to tackle VSDs, remember, which were thought to be off limits. The first patient had the wrong diagnosis, that died. The second had the correct diagnosis, but that patient died. He said, VSDs, still a no-go zone. Really the beginning of getting into operating on the open heart was from C. Walton Lillehei. This is pictured here in the left lower corner. And I commend you to read King of Hearts, which is the story of the University of Minnesota group and Lillehei. It was mentioned before. It's a great book and fascinating reading. So working at the University of Minnesota, he tried to develop bypass using the lung of an animal as a biological oxygenator. This is where they came up with the idea of cross-circulation, particularly for congenital heart disease. It was likely that a parent would have a similar blood type, be same as the child, and you could use a parent to cross-circulate and provide oxygenated blood and cardiac output for the infant, very much like the placenta. In fact, one of the co-workers, Lil High's co-workers, said, geez, maybe what we really need is a placenta. We need something like that. That's the sort of heart-lung machine. And this is a very simple cross-circulation. Basically, femoral cannulation, cross-circulation of the infant, and you could provide cardiac output to a patient with his or her heart stopped to operate on it. First surgical procedure, however, that was said to be able to have 200% mortality. You could lose not only the patient, but the cross-circulating donor. The first case that was done successfully was a VSD. Clarence Lewis was one of his colleagues at the University of Minnesota, turned it down. He knew it was a VSD, knew they were impossible to operate on. Watson, who was the chief of medicine, really tried to stand in the way, tried to stop the procedure. But the real hero in this was Wangenstein, who was the chief of surgery, not a cardiac or vascular surgeon, really a general surgeon at the University of Minnesota. And he was an innovator, at least not by proxy. And he said to Lil High, yes, you go ahead. This patient has no alternative, and you're the person for the job. He actually let this happen. It was very controversial, and it's outlined in the King of Hearts book. And so this patient survived. Heart was open 15 minutes and 20 seconds. Cross-circulation time was just short of 20 minutes. Unfortunately, the patient survived the initial operation, but died of postoperative complications, pneumonia, on day 11. So 6 out of the 8 next patients survived, but 1 out of the next 7 survived. So a very checkered beginning to cross-circulation. Interestingly enough, just like the Lauer story, one of the donor parents had a stroke, and he was sued over this. Heart block was a major cause of death in infants. And another line of innovation in this is the University of Minnesota and Earl Bakken. This was where cardiac pacing was developed largely as a result of this need. So cross-circulation really was cumbersome. It was thought to be potentially not ethical because you are placing someone else at risk for a potential patient's fatal illness. And the people beginning in cardiac surgery, Kirkland, Debakey, Cooley, they were all saying we need to have a heart-lung machine. And so Lil High and DeWalt went out to have a beer one day, and they noticed the foam beer, and they said, hey, this is a way we can oxygenate liquids. Maybe we can oxygenate blood this way, and that was the beginning of the bubble oxygenator. And these weren't just competing technologies because the bubble oxygenator was cheap to build. Membrane oxygenators at the time would be very, very expensive to build. And so this resulted in the beginning of the sort of cardiopulmonary bypass machine that we know today. And this was one of Lil High's first machines. And for cardiac anesthesiologists and perfusionists in the audience, this is not so different from the look of what we see today. So the bubble oxygenator was very successful, and by 1957, they had done 413 operations with this. And this really set the stage for what we'd call true open heart surgery. You know, it's interesting, people have had coronary bypasses. I had open heart surgery. Well, no, your heart wasn't open, right? People stuck needles in it and put bypasses on it, but you didn't have it flayed open and have some congenital defect closed. So this was the beginning of the ability to operate on the heart in that way. And it resulted in the modern, so-called modern cardiopulmonary bypass machine that you see there that's still largely misunderstood. Blood drains via gravity, it enters a reservoir, there's a roller pump or a centrifugal pump that pumps the blood, goes through the oxygenator, heart is stopped, fibrillates, cardioplegia is developed, delivered to the heart, and patients survive and are resuscitated. But interesting enough, it's still very poorly understood. This is stuff from Encyclopedia Britannica that has the circuit backwards, pumps in the wrong place. But we have a machine today that really is the scion of what initially was done. But so all of the above happened without IRBs, without multi-million-dollar corporate support, and not one single randomized trial. Never happened today. But it started people thinking, if we can stop and start the heart, then we can take the heart out of something and put the heart into something else. It could be dogs, it could eventually be people. So heart transplantation was really starting over in cardiac surgery. We knew that Bill Roth was wrong, right? You could touch the heart, you could sew wounds in it, you could cut it open, you could treat the heart pretty much like any other organ. Think about the time in the mid-1960s, right? This was the race to the moon. President Kennedy said, we are going to beat the Russians to the moon. We had a U.S. cultural notion that we could do anything that we set our minds and our money to. And so there was a race, a political and a scientific race, to be the first person, the first group, to transplant the heart. Just like there was a race to be the first group to sequence the human genome, this was true back then. And I can remember growing up on Long Island and listening to the radio and watching on ABC TV and seeing Adrian Kantrowitz outside giving a news conference after the first heart transplant. And I remember everyone in my town was glued to the TV. So Lillehei's children really started to work to understand heart transplantation, and hundreds, literally hundreds, maybe even thousands of dogs gave their lives in this effort. The groups and surgeons that you've heard before have tried to do this. Shumway in California, and Lauer later in Virginia, who Shumway credited as being the brains behind the operation, and plus the US-trained Christian Barnard in Cape Town readied their teams. They searched for donors and patients, and of course, they all, with the exception of Kantrowitz, thought about transplanting adults. Barnard, by circumstance, by culture, by everything else, by shrewdness, won the race on December 3rd and became, as you know, instantly famous. But he used techniques, of course, that were developed by others. And this was outlined in another work that I commend you to, Every Second Counts, which was also talked about before. Fascinating reading for anyone who's interested in cardiology, and it's fascinating reading for anybody interested in the time and in politics. So Kantrowitz was reasoning things a little bit differently. So he said that neonates and infants might be more immune tolerant than adults, right? There are lots of things that point to that. Neither the donor nor the recipient will have a lifetime of other illness burden, right? They're newly minted human beings. And anencephalic infants, of course, that have no chance of survival may be appropriate donors. And of course, as we talked about before, he was pushing for the concept of brain death, which was not yet incorporated in the US legal mindset. Hypoplastic left heart and other non-survivable congenital defects may be candidates were the best for receiving a heart. So you had a sort of natural biologic situation that really went to this, both ethically and situationally. And so, as we know, he performed the first pediatric heart transplant on December 6th, right here at Maimonides, and it was technically successful and went pretty much as you saw the dog movie, really a tour de force surgically, with profound hypothermia of the donor and the recipient. Interestingly enough, Kantrowitz and his colleagues wanted to keep this under wraps. They had not wanted to have this public furor over the whole thing until they had done more than one transplant. The business with Barnard 3 days later made it impossible for them to do that, and this had to be done very publicly. Kantrowitz went and he gave this very, very impassioned news conference, and he said, after the death of the recipient, that this case should be considered a complete failure, which of course was his humility, but was completely wrong, because although it seemed to be a technical and a medical failure, there was a lot in this that was successful, and he went on to talk about this. And he was somewhat sanguine about heart transplantation. He said results of the first 101 heart transplants performed around the world in the year after the first one were disappointing. Only about 25% of the patients live longer than a few months. And as we've just heard about modern heart transplantation, we've certainly come a long way since then. So what are the universal lessons learned from this, and how am I going to connect this to transcatheter valves? So we figured out how to transplant the human heart only after becoming comfortable operating on it. So we learned how to do cardiac transplant surgery. More importantly, the clinical results made us redefine death because this was the whole business of moving to brain death as opposed to cardiac standstill. We had to learn immunology, immunosuppressive medicine. We had to improve clinical care, and we had to consider the long-term effects of doing this, all of which you heard about in the last hour. So the legacy of Kantrowitz and the cardiac transplant pioneers isn't really one that is just medical. It transcends medicine. It's one of the patient's hard work and understanding that it's not only doing something, but it's preserving the results, the durability of results. That's what drives heart transplantation. How long do the organs last? How long are patients living? What are alternatives? The durability of results is really important. So if we can transplant the heart, but we can't yet preserve the results, can we replace its worn parts? So concomitantly with thinking about heart transplantation, there was also a thought about valvular heart disease, right? Still, not a single randomized trial in cardiac surgery or cardiology to address any of this. Still, no complex IRBs. Still, no huge amount of corporate support. The evolution of valve surgery really came about on a parallel path. Albert Starr in Portland really was the father of the mechanical heart valve. The Starr-Edwards valve, implanted in the 60s, revolutionized valvular heart disease surgery. In the 1980s, 70s, and 80s, tissue valves were developed, which obviated the need in some cases for anticoagulation and really made surgery much better and more applicable. And in 1990s, we started to think about the mitral valve and how valve repair became surgically possible. The gold standard for severe aortic stenosis in 2000 was this: median sternotomy, surgical aortic valve replacement with a biological prosthesis. As this was happening, we also were in the stent revolution. And Henning Anderson was a cardiologist who went to Phoenix to see Palmaz and Schatz talk about their coronary stents. And he says, on the way back on the plane, I thought, everybody's trying to make stents smaller. I think I'm going to make them bigger. A very simplistic notion. And he said, you know, I think, without having really any training in this, I can make a stent and I can put a biological valve on it, and I can use this in a transcatheter way to implant valves in patients. So he went home, literally in his garage, he took sternal wires, fashioned them into a kind of a stent, as you see here in the lower left of this, and sewed bovine valves, aortic valves, onto them, and implanted these in the abdominal aorta of about 40 pigs. There's a picture of him in the hospital where he worked cath labs. And if you talk to him, it's a fascinating story about taking these draped, anesthetized pigs through the basement of the hospital at night so that nobody would see them. But he did this very carefully and very, very calculatedly, and applied for patents for transcatheter valve delivery. And of course, he knew that this needed to be kept secret, and it needed then to be published, which he tried. And he gives a fascinating talk. He kept every rejection letter that he got from every journal. And here's one experience he sent to Simon Dack, who was then the editor of JACC. Thank you for letting us see this manuscript. I have to reject it, but my overall rating is that it is too low a priority for publication. Comments of our reviewers are enclosed. The comments basically said, this guy's off his rocker. This will never work. Of course, it did work. He was one of the co-founders of PVT, and Alain Cribier implanted the first transcatheter aortic valve in France in 2002. This patient's no longer with us, but he lived about 6 years thereafter. This was done transeptally, and Alain is, if you've ever heard him speak, he's a marvelous speaker, speaks with a great French accent. And the first time I saw him, he gave a little talk. There was a piano on stage. He walked over to the piano and he started to play Chopin nocturnes. And I said, boy, I hated him before. I really hate him now. So the early transcatheter valve experience was quite interesting. So here's an early shot from France. Does this look like a relaxed group of doctors? Not at all, okay? And here's the reason why. The early valve delivery was fraught with difficulties. This is a case of mine from the Partner 1 trial. You see the valve rises, balloon comes down, pacing goes off, and the valve is ejected into the aorta. Right? So that's why people weren't very relaxed. It was very easy to do this. But of course, innovation is important. This was a skirtless valve. The sheath was 24 to 27 French. It was done with general anesthesia, PA line monitoring, TEE, and you saw how rapidly we deployed the valve because everybody was frightened. Get the balloon up, get the valve in place, get the heck out of there, okay? Things are very different now. Currently, valves are deployed very slowly because we know that we can keep the valve in place that way better. It won't move around. And this happens time and time again. These are 3 recent cases with a skirted valve, a small 14 to 16 French sheath, no transesophageal echo, no PA line, no general anesthetic, and slow deployment. So we're getting closer and closer to being able to do this the way you would do a coronary angiogram and a PCI. And most patients now go home, whether they have it at the Brigham or whether they have it at Central Maine Medical Center, the following day. Does this work? You've all seen this. Partner 1 trial of inoperable patients, 20% absolute reduction in mortality compared to best medical therapy for patients that are not operative candidates at a year. A real life and changing study that revolutionized the treatment of aortic stenosis. In high-risk patients, TAVR is non-inferior to surgery in high-risk patients, better quality of life at 30 days. That's very important to people who are octogenarians, who don't have 6 months to spend recovering. XT valve demonstrated a significant advantage over surgery in intermediate-risk patients, with a nearly 16% mortality or disabling stroke in patients in the surgical arm and about 12% in patients in the transcatheter valve arm. And SAPIEN 3, a 75% lower incidence of all-cause mortality and disabling stroke 30 days compared to surgery in intermediate-risk patients. In low-risk patients, the Partner 3 trial recently stopped enrolling, so we reached our enrollment goals. And we'll see, the results are blinded, but this may well be the death knell for cardiac surgery, for valve replacement of the aortic valve in patients with low risk. And we'll probably come to a situation in which it's not going to be the patient's risk, but perhaps the patient's anatomy that determines who gets what valve when. In terms of cost, in the mature era, without general anesthesia and without intubation and with very, very thoughtful selection of patients, the cost of transcatheter valves is lower. Improved quality of life, which we've talked about before, and these benefits are not just realized in trials. If you look at Medicare data, we certainly have a very, very robust data set that transcatheter aortic valve replacement is becoming the new gold standard. Aortic stenosis remains underdiagnosed and undertreated. Many, many primary care physicians may see patients in their 70s or 80s, say, oh, they have a heart murmur, they had an echo at age 65, it wasn't a problem, so it's not a problem now. And these patients go on to become sick, and many of them die because of aortic stenosis. So we now need to discover aortic stenosis, we need to treat it aggressively, and we have the option of transcatheter valves. So, problem solved, we're on to the mitral valve, right? So 2002 first valve, we're 15 years later, mitral valve should be a piece of cake, right? Well, it's also important, right? There's twice as much mitral valve disease, mostly mitral regurgitation, as there is aortic valve disease. And it spans a wider range of patients. So we should be able to plug in the mitral valve just the same way, right? Well, not really. Because the mitral valve isn't just a valve, it's a system. And the important part of understanding transcatheter valve therapy for the mitral valve is not the devices that are out there, but the anatomy and physiology of the mitral valve, which is really important. The aortic valve is simple. It's an on-off valve. The mitral valve, not so much, right? It's much more complicated, more bells and whistles, more dials to turn. Interestingly enough, this has informed the treatment of valvular heart disease. The early surgical treatment of aortic valve disease was to repair or decalcify the valve. That didn't work because the underlying process wasn't altered, and it became clear very quickly that the aortic valve needed to be replaced when it was dysfunctional. Mitral valve surgery started out in the pre-bypass era for mitral stenosis as repairing the valve. Not necessarily very well, but repairing the valve, and it became clear that, well, we had now prosthetic valves, we can replace the mitral valve. Only later on, with improvements in technique, was it clear that replacement for the mitral valve wasn't going to be the gold standard treatment because it's not just the valve. It's an entire system that is much more difficult to work with. And so we developed mitral repair for patients with mitral regurgitation. The mitral valve apparatus is extremely important to think of as a system. You've got the leaflets, you have the mitral annulus that have this chordae, the suspensory apparatus of the valve, attached to the papillary muscles. You have the left ventricle that needs to function in a normal way with good tethering of the leaflets, good tethering of the papillary muscles, and the shape of the ventricle is very important. The leaflet anatomy is much more complicated. The leaflets are living, and they undergo remodeling, so they're not dead tissue. The posterior leaflet is attached to about 2/3 of the annulus, the anterior leaflet about 1/3. Posterior leaflet has scallops, but these scallops can be of varying anatomy. The commissures may be small, they may be large, they may have pseudocommissures. The line of coaptation or the line of regurgitation is not as clear as it is in the aortic valve. So even the leaflets are much more complicated than the aortic valve, and they're living tissue. So they undergo degeneration and they undergo remodeling with the passage of time. The mitral annulus, unlike the aortic annulus is basically a sort of ovoid on one plane. The mitral annulus is saddle-shaped, and it's saddle-shaped very dynamically. This changes the leaflet stress during parts of systole and diastole because it's saddle-shaped. So already you're seeing some of the difficulties. We have a non-coplanar annulus, and we're going to try to figure out how to fix or replace this valve. It is very different from the aortic valve. The annulus is partially fibrous, and it tends to dilate in the anteroposterior direction, not just circularly. It is D-shaped or shaped like a lima bean, and so you have not a round annulus even in one plane and saddle-shaped in two planes. The chordae are very important. There's no chordae on the aortic valve, right? So they keep the mitral leaflets from prolapsing, they keep the valve from regurgitating, and there are multiple chordae, right? There are primary, secondary, tertiary chordae, even strut cords that support this valve. So you can see it's getting more and more complicated all the time. They're also living. They have blood vessels in them that also supply blood to the leaflets, particularly the base of the leaflets. And the papillary muscles, which tension the chordae in systole, prevent the valve from regurgitating. Also a part of the system. And dysfunction or displacement of the papillary muscles, dysfunction from infarction of the papillary muscle, displacement from dilatation of the ventricle, particularly the posterior papillary muscle, results in mitral regurgitation because changes in the way the leaflets are suspended. The left ventricle is also a part of the valve system because it can dilate, it can develop dysfunction, and it can tether the papillary muscles, it can dilate the annulus. Ventricular function is very important. Right ventricular function determines what happens to the patient because right ventricular function really right ventricle supplies blood to the left ventricle, thinking simplistically. So in situations where you have left heart failure related to mitral regurgitation, you also can have right heart failure related to the left heart failure. Right heart dysfunction is much more common in long-standing mitral valve disease than it is in long-standing aortic valve disease. So automatically the patient subset is becoming a little bit more complicated hemodynamically. Mitral regurgitation creates mitral regurgitation. Even when there's something primarily wrong with the valve, and you have degenerative mitral regurgitation, the volume overload for the ventricle produces secondary mitral regurgitation or functional mitral regurgitation. So although we class MR into two types, functional and degenerative, degenerative leads to additional functional mitral regurgitation with the passage of time. There are multiple types of MR classified by type that talk about leaflet function and ventricular function and dilatation. Very important for mitral valve repair. And the phases of mitral regurgitation are very different from the phases of aortic stenosis. There are several levels of asymptomatic mitral regurgitation. Many patients who are asymptomatic, if you delve a little bit deeper, they have a little bit of a dilated ventricle. They have something physiologically wrong with them, but they're still essentially asymptomatic. And then with varying symptoms, patients have more and more ventricular dysfunction. Dave Adams likes to say that if you operate on the first level of patient, the asymptomatic patient, you're doing a curative operation. If you operate on anybody else, you're doing a palliative operation. Because unlike aortic stenosis, the volume overload from mitral regurgitation really, once the ventricle is affected, it never returns to normal. But AS, once that's corrected, the ventricle may return close to normal. So what about the transcatheter approaches to mitral regurgitation? Each one of those areas has been approached by a transcatheter treatment. The leaflets have been clipped. There are ventricular shape change devices. Coronary sinus, which is nearly but not always coplanar with the annulus, has been used as a conduit to cinch up the annulus. And there are a variety of percutaneous annuloplasty methods that have come into and out of favor. We all know about the MitraClip, which clips the edges together for degenerative mitral regurgitation to prevent posterior leaflet prolapse. It's also used increasingly commonly in functional mitral regurgitation. It simulates the surgical Alfieri stitch. There are more transcatheter approaches to mitral regurgitation every day, and here's just a few dozen that were very, very commonly thought of in 2013. There have already been device and commercial failures. Edwards has had several failures, both the Mobius and the Monarch devices. St. Jude has had failure. Coapsis out of business. Cordis, which was once in business, has failed. There have been multiple failures of this, just like there have been multiple failures of cardiac transplantation. Because the coronary sinus is necessarily nearly coplanar with the mitral annulus, one of the first devices was the Carillon device, which went into the coronary sinus, had an anchoring end distally and an anchoring end proximally, and would cinch the coronary sinus. And you could reduce the annular dimensions with the device. Well, coplanar with the sinus is the annulus, but also is the circumflex coronary artery. And so one of the issues with this is that the circumflex could be injured. Another issue with it is that the coronary sinus is used for cardiac resynchronization therapy, and this may or may not interfere with that. There have been clinical trials that have shown improvements in ventricular size and shape, but there's not a clinical trial that has shown patient benefit in terms of survival. Other mitral annuloplasty devices, the Mitraline, which does a kind of K commissure fusion, AccuCinch and the Cardioband were all catheter-based placements of basically mitral rings. The Mitraline is a very complicated device. It's been used in man to do basically a K annuloplasty to the mitral valve. AccuCinch, same thing, placing a kind of tethered ring percutaneously, and the Cardioband, the same thing, same kinds of things. Other approaches were to put a balloon into the mitral annulus to provide a spacer, to give the leaflet something to coapt against, to prevent the leak of blood back into the atrium. In general, thinking about all these devices that have gone before, that exist now, or to come, why is mitral repair so delayed from a transcatheter approach? Well, the disease is complex, it's complicated, it's much different from aortic valve disease. Even the role of surgery, which is the gold standard now for treatment of mitral regurgitation, is unclear. The role of surgery in functional mitral regurgitation is controversial. There have been a number of recent cardiac surgical trials network studies that have shown that mitral surgery at the time of coronary surgery for moderate mitral regurgitation that's functional is probably not effective. There's no single approach from a transcatheter standpoint that does everything that the surgeon can do visualizing the mitral valve. The surgeon can resect redundant tissue, the surgeon can put in a ring, the surgeon can do an Alfieri stitch, the surgeon can look at the valve and test it while the patient is on bypass. None of the percutaneous techniques come anywhere close to being able to do that. So we're going backwards now. The surgical gold standard is repair, but what about replacement? We've got to figure out how we can get a mitral valve into the patient from a transcatheter approach. But right, mitral valve replacement is out, it's dangerous, right? So mitral repair is better than mitral replacement. We look at this mortality in patients that are high risk. It can be as high as 25% for mitral repair, right, mitral replacement rather. And so surgical replacement is bad, or, well, is it? We don't really have randomized trials of repair versus replacement in patients that are candidates for both. Yes, if the valve can be repaired, those patients seem to do very well, but there's not a literature of randomized trials. We're increasingly pushing for that, but there's not. So the challenges for transcatheter mitral valve replacement are largely technical. You have to fold the valve, somehow get a big valve into the heart, like building a ship in a bottle. The orifice is oval-shaped, so it's hard to put a round valve in a bean-shaped orifice. And the valve sticks down into the left ventricle. We know about outflow tract obstruction with surgical mitral valves, and certainly transcatheter valves, which are not placed under direct vision, could obstruct the outflow tract. Interference with the subvalvular apparatus, paravalvular leak, which isn't well tolerated. But there are a number of prostheses. They all basically have a similar kind of anchoring mechanism with a larger flared area in the left atrium and something that anchors them to the mitral annulus. Here's a first in swine of the Tierra valve, which has since been put in man. And there are others that look very much similar, some of which have gone on to clinical trials and some of which haven't. This is the most important slide for this part of the talk, to look at the differences between the aortic situation and the mitral situation. Much more complex in the mitral situation, right down the line than in aortic valve replacement. The current peer-reviewed status of transcatheter mitral valve replacement is really about to change, however. This is a article that's recently been accepted to JACC about the Medtronic valve and its follow-up. 50 consecutive patients out of 166 that were screened, class 3 to 4, so very sick patients with severe mitral regurgitation. Age in their 70s, mean STS moderately high, 6 for a mitral valve patient. Ejection fraction moderately reduced. Mean follow-up of these patients, 173 days. And that, by the way, is the prosthesis. The left atrial side's at the top of the screen and the ventricular side's at the bottom of the screen. And this is what it looks like on TEE, before the TEE showing the valve and after showing flow through the valve. The gray bars here are patients that succumbed. Device implant success got in 96% of the time, so you have to be able to get this thing in place, which has been done. No device malfunction and no device thrombus. 30-day mortality, 14%. I'll go into this a little bit. Mild or no residual mitral regurgitation in all patients, and symptom improvement at about 80%. Residual mitral regurgitation is virtually nil in these patients, and certainly only mild mitral regurgitation, the green, exists. So technically very, very successful, both the 30 days and the last follow-up. And most importantly for the patients, NYHA class dramatically improved in these patients. So here's the causes of death in the 11 patients that died in this study. And if we look at this, 4 out of 11 were procedural deaths. Hemothorax, device malpositioning, laceration during apical access, postoperative apical bleeding, and these were all transapically done. So those things are all easily solved. Just like the technical issues of heart transplantation are solved, those things will be solved. So I think that there's about 30% of the deaths that are going to be reduced from technical improvements in the device. So we've got really a first-generation device in a group of patients that are like those that we encounter every day, not randomized though, that shows extreme promise in being able to fix the mitral valve transcatheterly. And even the ACC is hyping this, saying that trials suggest TMVR may become an alternative to surgery. This was from last week. So is this innovation? So it took 100 years to get from the Model T to the Tesla. It took 50 years to get from the UNIVAC 1 to the iMac Pro. And does this look like innovation? Right? There's Gibbon's machine, there's the Lillehei machine, and there's our machine. Now, they don't look a whole lot different, right? The bells and whistles are a little different, but the lines and the tubing and everything, and it's very complicated. I mean, any cardiac surgeon knows that he or she owes a lot of their good results to their perfusionists, because it's complicated to run this thing, right? You would think that after 50 years, that machine would be a lot less complicated and easier to run. And the question is, why isn't it, right? Why haven't we gone on to this? Now, I would say that the issue is that we're giving up the innovation fight in this country, right? Kantrowitz had $3 million in grant money from the feds, right? You can't get that today, right? The federal government has gotten out of the business of supporting basic device research. It's all corporate driven, and corporate drives these things based on the ability to make a profit. Cardiopulmonary bypass equipment manufactured by 2 or 3 companies isn't a profit maker. There's no incentive to improve the pump. We need to bring back that incentive to improve the pump. $2 billion was spent before the first transcatheter aortic valve was sold in the US. $2 billion. That dwarfs the $3 million in grant money for heart transplantation. Significantly more is going to be spent on the mitral and tricuspid areas before we have anything that we can use clinically on a day-to-day basis. So the legacy of Kantrowitz in cardiac transplantation isn't just heart transplantation, it's innovation, right? His real courage was the fact that he didn't listen to the people that he shouldn't listen to, and that he did what needed to be done, and did it courageously, and did it ethically. He knew that diseases desperate grown by desperate appliance are relieved, or not at all, as Shakespeare said in Hamlet. And I want to end with a remembrance. So David McIntyre Bashaw was the donor for the first heart transplant done here, and Jamie Scudero was the recipient. And I think we should remember that everything that we do every day has been on the backs of patients, and that everything that comes in heart transplantation, in transcatheter valves, in fixing diseased aortas, has to consider the patient first. Thanks very much. Out of here. Oh, thanks.
So then would you you and Dr. Davidson would have been the ones who started the CABI program there? Oh, okay. So Mark just missed you. He would have loved working with you.
Yeah, so he came after Mike.
Yeah. True enough. Is that right? Here we go. There you go. Yeah. Lucky.
Okay, if everybody could take their seats and we can get going with the rest of the program. So we're going to get started with the rest of the program. So the rest of our program will consist of one more invited lecture. There will be a panel discussion afterwards for questions, and there will be a short plaque presentation, not atherosclerotic plaque, but a regular plaque. And going along with the sort of history of heart surgery and transplantation that we've been talking about, I wanted to mention my favorite quote from Walt Lillehei, who you heard about today. And I use this in a lot of my lectures, but I think it's very applicable to the things that we do in medicine and how we learn. He was quoted as saying, "Good judgment comes from experience. Experience comes from bad judgment." So with that, I'm going to invite up Dr. Robert Ree, our head of vascular surgery, to introduce our next speaker.
Good morning. I hope everybody's refreshed, and I wanted to introduce you to our next speaker. It's my distinct pleasure to have Dr. Cherry Abraham to visit New York City today. He is an innovator, and this is a little bit different than heart transplantation, but I noticed on his CV that he did spend 6 months in the xenotransplantation laboratory during his general surgery training. So that's his little link to transplantation. But he is an innovator. He will discuss really the past, present, and future of a sort of a forbidden area, sort of like transplantation, the aortic arch. It is an area where traditionally surgery has been the mainstay treatment, and it's really been the only treatment. And just within the last 10 years, have there been any exploration into minimally invasive treatment of this region, the aortic arch? And it's a hostile area, fraught with complications if something goes wrong, including mostly related to stroke, and he'll discuss all that. But just to give you a background on what he has, what his accomplishments have been, he actually is from Nova Scotia, Canada. He did his undergrad medical school and general surgery training at Dalhousie Medical School in Nova Scotia. He went on to Western Ontario to do his vascular fellowship. And he spent about 6 months in New York City at Montefiore training with Frank Vieth and Todd Oki, who many of you know, and spent another year at UC San Francisco in Australia to learn the complex branch graft techniques. A couple of notable achievements is that he actually was the very first person in the world to place a multi-branch endovascular aortic device in the aortic arch, and this occurred in 2009 at McGill, where he was on full-time faculty. So this occurred at Jewish General Hospital, which is part of the McGill system, in October of 2009. So this is quite a landmark achievement. He's also been assisting other centers to get started on their aortic arch programs. But unfortunately, in the United States, these devices are available only on compassionate use because of some of the early negative experiences with this type of an approach have prevented the significant progress which should have occurred by now in this type of therapy. So without much ado, I'd like to introduce Dr. Cherry Abraham, who is currently the director of the Aortic Center at the NITE, or the Nike Cardiovascular Institute. Thank you.
Thanks, Robert. Thanks for that kind introduction, and thank you, all of you, for letting me be part of this special day. Those were great talks by both Dr. Eisenhower and Dr. Lima, so it's tough acts to follow. I think we need to get some housekeeping out of the way. Is there... There we go. So those are my disclosures. Very important one at the bottom of the page is that much of what I'm about to tell you is off-label use of commercially approved devices, and/or I'm describing devices that you can only use if you have an investigational device exemption. I was going to disclose that I'm a Canadian, but now Robert has let the cat out of the bag. I will also disclose to you that wow, I'm really getting old now. This is what happens when you turn 50. You start to lose your memory a little bit. In 1997, I went and I thought I was going to be a trauma surgeon, so I went to Grootschuur in Cape Town, South Africa, to do trauma surgery for 4 months. And I came out knowing I did not want to do trauma surgery. But I assure you, by all accounts from the South Africans that I met down there, Christian Barnard was indeed a schmuck. So I think I'm going to start by, I've been tasked with talking about the past, present, and the future, and we'll talk a little bit about the past and go back to basics. So what are we have to change gears. We're not talking about the heart anymore. We're talking about usually aneurysmal disease of the arch or thoracic aorta, and what we're really trying to do is achieve a seal proximally and a seal distally and exclude blood flow from the aneurysm. We also do TVAR, or thoracic endovascular aneurysm repair, for patients with dissection, but the purpose of that is really we're trying to exclude flow from the false lumen and keep all the flow into the true lumen and try to achieve false lumen thrombosis. And those two things will be important later on. So as you see here in this diagram, we have a nice landing zone proximally, a nice landing zone distally. These are relatively simple procedures. In the last 10 to 12 years, we've had a lot of device innovation. We are now no longer obviously using first-generation devices. We're using second, third, and sometimes fourth-generation devices. This is what some of the stuff we had to put up with before. This is called a bird's beak abnormality, where the stent graft just doesn't conform. And almost all of the stent grafts, when they first came out with the first generation, had this problem. And then you develop type 1 endoleaks, basically an endoleak being continued perfusion of the sac from a leak in this area. We don't deal with this problem much anymore because devices are much better and they conform better to the aorta. But this will come a little bit more relevant later on when I talk to you about that first time we did that first in the world case in Montreal. We no longer, I shouldn't say we no longer, we hardly ever do a conduit. This is a picture showing us putting this large profile thoracic device into a conduit which is attached to an iliac artery, and the reason we do that is because the femoral arteries are too small. Now these grafts are becoming more and more lower profile, and we seldomly have to do that. They're also much slicker. When I was doing these cases back in early 2000s, these devices, you were basically, I call it my Mr. Burns moment from Simpsons. You'd be like trying to pull this graft out and trying to unsheath it, and it became very difficult. Now these things are so easy. They come in coil track delivery systems, and the devices are just so much better. They're also much lower profile. Imagine we're putting a 32 millimeter graft into a 16 French system. 16 French, you really only need a vessel that's about 6.2 millimeters to put a 16 French system, and that's really amazing. And what that's really translated to is all of a sudden, imagine these young 18-year-old trauma with thoracic tears, we're able to put these low-profile devices and save their lives quite quickly. So what I really want to concentrate is the aortic arch. And the reason it's so hostile, it has obviously, as all of you know, some pretty important arteries, the innominate artery, the left common, and the left subclavian. We know that the left subclavian is not as expendable as it used to be. We can't always rely on that right vertebral to supply the brain. Also, we know that a certain percentage of these patients end up having thoracoabdominal aneurysms, and they need that subclavian artery as a collateral blood supply to their spinal cord. So now we're really interested in saving all these arteries, not just 2 out of 3 or sometimes even 1 out of the 3. Aortic arch aneurysms, just isolated aortic arch aneurysms, are pretty rare. They usually, we don't see them. We usually see them more associated with a descending thoracic aortic aneurysm, or it's an ascending aortic aneurysm that involves the arch. So we're talking about pretty few and far between cases. A little blurb about the open surgical repair. Look, we know that the death and stroke rate is pretty low in high volume centers. We know that centers like Maimonides have really good quality cardiac surgeons, but not every center has that. And if you look at all comers, if you look at all centers, the risk for death and stroke actually is a little frightening. It's up around 10 to 15%. It's not the 5% that you often hear. And I think that's because you're including all sites that sometimes are a little bit lower volume, or you might have someone who's particularly good at doing aortic arch aneurysms, but that person can't necessarily be on call and is working 365 days of the year. So there may be an unmet need for a less invasive solution to this complex problem. I think we would all agree that some of these patients who have been had a sternotomy 2, 3, sometimes 4 times are really difficult to get back in, and these are another patient that might benefit from a less invasive option, such as an endovascular repair, or someone with a false aneurysm of a previous open repair might be someone who might be a good candidate. I think this underlies the importance of, the other disclosure is that I'm a vascular surgeon. I don't think that we should be really making decisions on just slamming in these endovascular devices without cardiac surgery input. I think we should do the patients that cardiac surgery either says they can't do or that they don't want to do, and then we have to make a decision on whether they actually should be done. So I'm going to concentrate on the hybrid procedures as well as I wouldn't say a total endovascular, it's more like a near total endovascular. When I first started doing these arch branch grafts, I used to show this slide, and I used to show it thinking that it was going to be part of history and that we would never have to do these operations. Now, 7 years later, I think this is a pretty good operation as long as it's done by the right people. I think a vascular surgeon that doesn't have that much experience in the chest, doesn't like doing this operation, doesn't even want to offer anybody this operation, I think that's unfair. The cardiac surgeons, we know, ascending aortic replacement in a good cardiac surgeon's hands has pretty low morbidity and mortality. And so I think doing a debranching is a pretty good operation. Where I think the art comes is when the cardiac surgeon knows what you can do, a graft off a native aorta, or I'm a big fan of just saying, let's just replace the ascending aorta if the cardiac surgeon is willing, because I think that's a better operation, replacing the ascending aorta and taking this Dacron graft off that. Because most patients, I think most of you would agree, if they've got arch pathology, I don't know how normal their ascending aorta is, especially mid to long term. So I'd like to start again in the past. Now let's take me back. I'm in Montreal, and I'm in Canada, so I'm doing these complex cases on a C-arm, believe it or not. And I've got a 48-year-old patient who was operated on by a cardiac surgeon for a type A dissection. This was a seemingly normal 48-year-old gentleman, and he had a tough time on circ arrest. When he came out of it, he didn't have any neurologic deficit in his extremities or anything like that, but he just wasn't right from a mentation point of view. You'd go in to see him, and if you came back 5 minutes later, he wouldn't remember that you were actually in that room 5 minutes ago, and despite speaking to you normally. So he had a tough time with his post-operative care, and even a tougher time with the CT showed that his proximal descending thoracic aorta had gone from 37 to 50 millimeters. This was 2 months later. And the cardiac surgeon talked to me about this patient and said, is there anything you can do? And as you can see, the arch is just not friendly to do any kind of endovascular device. And I'm going to see if this will play. As you can see, that is just not a friendly place to put an aortic stent graft. One, because it's a very narrow true lumen. Two, because we're talking pretty much about a diseased aorta, so you never know how an endovascular stent graft is going to behave in a diseased aorta. So we did what most surgeons do when they're not sure what to do. We decided to do nothing and just put our heads in the sand and send him home and say, why don't you come back in a month or two and we'll do another CT scan. This is just a 3D reconstruction showing his dissection, and even though that looks like the dissection is distal to the subclavian, we know his arch is involved as well. So he came back at 7 centimeters, and we knew we obviously had to do something then. He was symptomatic, and so this forced our hand, and this goes again, what can you use? The things you use every day, the endovascular technology you use in the thoracic and abdominal aorta, and can you use that in the arch? And so this is what we did. We did a left carotid subclavian bypass. The cardiac surgeons did the median sternotomy, and they debranched from his existing ascending graft with a bifurcated graft. They debranched. What I mean by that is they excluded his they did a bypass to his innominate and his left common carotid artery. I had already done a carotid to subclavian bypass, so we know we were going to get perfusion to that. And we always attach a 10 millimeter Dacron conduit to that graft. You can't see the conduit. You can see the stump of the conduit here. That catheter is actually in his debranching graft. I haven't quite yet got it into the ascending aorta. You can see the imaging is just terrible. This is all done with a C-arm. And then we got through and through access from that catheter. So now we have a wire going from his groin up into his arch of his aorta, out his conduit that's attached to his ascending graft, and out of the open median sternotomy. And that's what you see here. So this nose cone is this delivery system is being delivered transfemorally through the arch, and the nose cone exits out of the conduit. And I put a snap here. You can do most of this without doing angiography. I put a snap here to delineate where we're going to deploy the graft. We deployed the graft. Here's again where you use the skills. It's not just about pushing and pulling and deploying a graft. You need other skills sometimes. And he had a tremendous coarct here where the lumen was compressed. So we ended up using a Palmez stent in that area. We brought the stent graft down to his celiac artery, and then I just occluded his subclavian artery so that we don't have an endo leak from the subclavian into the false lumen. And there is what we achieved. Again, this is you're dealing with a dissection. You're trying to achieve false lumen thrombosis. And as you can see, we don't see any contrast in the false lumen anymore. No contrast in the false lumen, no contrast in the false lumen. So we have a success. And just at the end of the stent graft, there is contrast in the false lumen. That makes sense because we had to end the stent graft somewhere. The dissection goes into the abdominal aorta, and now we just have to follow him. So I think that was a good success, and that is something that we did in the past. But now it's the present, and this was done here in Portland, Oregon. We had a 66-year-old homeless gentleman presented acute epigastric pain. He had, we're not sure, is it a type A or a type B dissection? It's all nomenclature, really. Type B dissection is always distal to the subclavian. Everything proximal is supposed to be a type A. But this really, as you can see, the ascending looks pretty free of disease, although as you can see, the arch is a little bit dilated, and I wouldn't call this normal. I don't think anybody would call this arch normal or not at risk of a possible retrograde. The indication for operating in this gentleman was more his epigastric pain, his renal malperfusion, and as you can see, there's a good example of a compressed true lumen. So imagine this compressed true lumen is giving blood flow to his kidneys. No wonder he has malperfusion. And as you can see in this CT slice, he has a hematoma. So there's obviously an indication to fix this, but what are you going to do? How are you going to fix this? In this high-risk patient, there's an option of doing an elephant trunk, where the cardiac surgeons replace the ascending and arch and drop a synthetic graft. But we try to use what had worked for us before, and we ended up doing again, a combined approach, left carotid subclavian bypass. The cardiac surgeons were able to use that for their arterial cannula. We sewed, while they were opening up the chest and replacing the ascending aorta, I was sewing the two 10-millimeter sidearms on the ascending graft that they were going to use. They sewed it in, they finished it both anastomosis, and then again, we used a conduit. This shows intravascular ultrasound, which is really important to make sure you're in the true lumen, because if you're in the false lumen, you can either have a disaster, and you don't want to have that. So the IVUS is always used whenever we do these dissection cases. So I think with presentations like that, it's always good to give you some of the pitfalls so that you can learn from some of the mistakes that we made. We had some difficulty removing the delivery system, and because of the angle in the ascending aorta. And I'm going to show you what happened. We had some slight distal movement of the stent graft when we deployed. And as you can see here, there's a little bit of an endo leak here. And there we've deployed the graft. Everything looks okay, except for that endo leak. But do we treat that endo leak there? And then 90% of endo leaks go away on the first postoperative CTs. We decided to not do anything at that point. But the postoperative CT, while he was in hospital, showed there to be an endo leak. And we thought, well, this must be a type 1 endo leak where it's coming from the proximal stent. But look over here. This is the subclavian artery, and this is the tie that the cardiac surgeon had tied on. And this is one lesson I learned. No matter how good friends you are with the cardiac surgeon, no matter how much you trust the cardiac surgeon, don't trust the cardiac surgeon when they tell you that they can tie off the subclavian artery with ease through the chest. That's not an easy thing for any cardiac surgeon to do. And then the other main problem is it's deep in a hole, and if that tie scissors through that artery, that patient is going to be dead. So they can be forgiven for not really cinching down too much on that knot in the subclavian artery, and that's exactly what happened in this patient's case. So basically, I proved that was the problem. I came from the left arm, did an angiogram, and there's the tie that's not quite complete, and that's where the leak was coming from, and that's an easy fix. We just put an Amplatzer plug in that artery and fix the leak. So those are the two lessons learned. The subclavian artery, we have other ways of occluding that subclavian artery with plugs, coils. We don't need the ties, so don't ask your cardiac surgeon to do the almost impossible. Just do it yourself. And then the other thing that I learned about this is not as bad an operation as I used to think. I actually think this is a good operation when it's done in the right hands. Going back to that pitfall I told you about, the one lesson that I would ask all of you to learn from is, and if I had to do this differently, the chest was open. There's absolutely no reason why I couldn't have just put an umbilical tape just around the synthetic graft. We could have put the graft down to the ascending aorta, and then if you tie the umbilical tape down just to make a little bit of a waist in the Dacron graft, when you deploy that stent graft, that first stent will be distal to the waist, and you won't get any migration of that stent graft, number one. And number two, it'll take care of any potential endo leak. So that's my little tidbit for you. Sometimes we get, the slides aren't working. This is supposed to highlight a bunch of different debranching options, whether they be carotid subclavian, carotid, or sometimes, especially in patients who have aberrant right subclavian arteries, you have to also add a right carotid subclavian. But what we're trying to do here is we're trying to bring the seal zone more and more proximally. And when you cover the left carotid, in order to get the seal zone here, you have to do a carotid-carotid bypass. Those are not necessarily minimally invasive surgery, a carotid-carotid bypass. So again, it may beg the question, can we do this in a less invasive fashion? This is just an example of a case we did early on, again, with C-arm fluoroscopy of a debranching procedure. We had such good results with the fenestrated grafts, with the scallop graft that we were using in the abdominal aorta. We thought, why can't we use that in the arch? So how it works is you deploy this graft. So let's say this scallop is for the innominate artery. This is your preloaded catheter. So before you deploy the graft, you send the preloaded wire out the preloaded catheter, snare it from the right arm, and then now that you have that wire, that through and through wire, it makes sense. If you pull up on that through and through wire, that scallop or that fenestration has nowhere to go except to the greater curve of the arch in line with the target artery. And there you see it here. Looks like a nice result. We have a fenestration or a scallop perfusing the innominate artery. I've debranched his carotid, so it's a right to left carotid bypass, a left carotid to subclavian bypass, and everything looks great. The problem with these cases that we were first doing, these were custom-made graft cases under special access permission from Health Canada. These were not available in the United States. The stroke rate was 25% in some of these cases, in all of these cases, and I think it was because we were flossing the innominate artery with that through and through wire. So we went back to the drawing board. So what are the challenges of doing branch grafts in the aortic arch? Well, it's complex anatomy, a lot of strain with the ascending aorta in that position of landing a stent graft. And do we really know how long that's going to last, midterm, long-term, especially in the ascending aorta, especially when you have these important branches that are perfusing the brain? And then this final thing, how do you oppose a graft to the inner portion of the arch here without getting that bird's beak abnormality that I showed you earlier? So this is a thoracoabdominal branch graft used in the thoracoabdominal aorta for thoracoabdominal aneurysms, where we deploy the branch graft. We come from the left arm. We get into each of these branches sequentially, one for the celiac, one for the SMA, bilateral renal arteries, and we extend into the target arteries with a covered stent. And then you have exclusion of your thoracoabdominal aneurysm. Well, why couldn't we use this in the arch? Why couldn't we use this? No reason really, except someone had to do it and someone had to try it first. So I had a pretty good relationship with Cook. I had made a pretty good reputation, and I was helpful to them by flying around Canada and helping interventional radiologists and other vascular surgeons as well as cardiothoracic surgeons perform their first thoracoabdominal repairs. So all of a sudden we had this patient who presented, and as you can see, the seal zone here without doing a debranching is not great. And this patient wasn't the greatest debranching candidate from an anesthetic point of view. I believe he had had a previous lymph node dissection on the right, and we thought we had the right candidate to try this. He was willing. Health Canada gave us permission after mountains and mountains of paperwork, and we did this first case in October 2009. It seems simple enough. You deploy a branched arch graft in the ascending aorta. You have to line up these branches so that they land directly underneath the innominate artery and left common carotid artery. You come from the right arm, at least early on, and keep in mind this was the very first case, so I came from the right arm and came down the innominate, found the branch with a catheter and wire, and then I extended with a covered stent into the innominate. On the left side, I had done a left carotid subclavian bypass, so I came from the left arm, came up the left arm, up the left carotid subclavian bypass, down the carotid, and found the branch, and then extended this up into the left common. Sounds a little bit simple when I talk about it. It took a long time, and there was by no means do I think it was anywhere near the magnitude of the first cardiac transplant that was done here, but it's nerve-wracking, and when you have 30 or 40 people in the room watching you, the one thing for sure that goes through your mind is that you're never going to do this again. You're never going to have anybody come watch these cases again. Because I can tell you, I suspect in that heart transplant case, not a lot of people gave a lot of input, but in these cases, everybody's got an opinion. And those are not the times to listen to opinions sometimes when it's the very first case. But this is the completion angiogram. Everything looks great there. What we really didn't know was there was a small type 1 endoleak, and it went back to that bird's beak. There was a small bird's beak abnormality there, so the blood was getting around there into the aneurysm sac. The other thing we noticed during this case is We deploy this branch graft. We do spend all this precious time getting into the branches, getting all our supraortic branches in and perfusing the brain, but we forgot that we had to put a second piece in. And you can imagine putting a second piece in, if it goes smoothly, it's no problem. But what the second piece did is it got caught at the end of this first piece, and it started pushing our entire branch graft up. And so we had to take a break. We had changed our diapers. We came back in the room, and we got out of it with some endovascular skills. Again, I used a coda balloon to bring back the telescoped portion of the branch graft, and then what I did is I came from the other side, and I was able to do it with a double Lunderquist, a double Buddy Lunderquist technique. And we had a success on our hands, and that was how the first branch graft went. But what I'm most proud of with this innovation and what this translated to, this is the iteration of the first branch graft that we put in. And subsequent branch grafts after that never looked anywhere near what this looked like. So in my mind, we really had made a difference. We had changed things. Because of the difficulties that we had had in that operation, because of the troubleshooting that we didn't just go and say, okay, let's see how the next one goes. We actually went back with the engineers and we thought about it, and we changed the external funnel-shaped branches to these internal branches, so that the funnel-shaped branches wouldn't push up against the arch and we'd have difficulty cannulating them. We changed the first stent to this was one of the first times they used the Profor adjustment, where this conforms much more to a very tight ascending aorta or arch, and now this technology is used in all of Cook's thoracic stent grafts. So we went from this iteration in the first case, and now since then, globally, there's been about 150 to 200 of these branch grafts done, and they all look like this. So I'm pretty proud that we were part of that whole transition from that first stent graft to what we use now. So just a little bit of the details about this case. We do usually, as a first stage procedure, left carotid subclavian bypass. It's a transfemoral insertion of the stent graft. Positioning of the device is extremely important, because if you get the branches wrong, you're going to have a really long day, or you're going to have a patient who's going to be not doing well in the ICU with no blood flow to their brain. We have to deploy it under rapid pacing, at least we thought so, but I'm going to tell you about some cases that we did in Brazil and in Colombia where the anesthetic support was not ideal. We didn't get the rapid pacing that they had promised, and we ended up deploying these grafts under permissive hypotension. And actually, I would say now it's not really mandatory to have to do this under rapid pacing. So, as you can see here, it's very important to know the markings. You need to make sure these markings are under the target arteries. You need to make sure you're not going to cover the coronary arteries with that proximal stent. Once you put this graft up, if those branches are up on the wrong side and not on the greater curve, it's game over. You're not going to deploy this graft, because once you deploy the graft, you have no ability to turn this graft. You can imagine it's a pretty tortuous segment of the aorta. How do those branches end up on the greater curve segment? It's a pretty simple innovation, actually. It's a pre-curved nitinol cannula. This is what it looks like with a stiff wire. This is what it looks like without a stiff wire. So no matter how hard you try to put this in the wrong way, as soon as it traverses the arch, it rectifies itself, and those branches end up on the greater curve. And I would say I've done maybe 100 presentations on the arch branch graft, and I always said that we've never had a problem. I did a case, I flew to Montreal last year to do a case in the Heart Institute with the cardiac surgeons there, and we actually had a problem. We put the graft up, and I couldn't believe it. I said, you know, I've been speaking about this topic for the last five years, and I always say that we never have to worry, but the branches are always in the greater curve. But when we put it up, the branches were on the inferior curve. And so we talked and talked about it. A couple of people in the room said, no, I think you should just deploy it. I'm sure it's going to rectify itself. And I was like, I don't know. I think that's a point of no return. So we finally backed out, and we figured, you know, I don't know why that happened. We actually deployed the graft on the bench And sure enough, it had been packaged wrong, and it had been turned 180 degrees in the packaging. So there's a good lesson. Don't make up things and think, oh, everything's going to be fine, we should just deploy it. If it's not right the first time, you do no harm. Take it out of the patient. And there's the angiogram. Before we get the angiogram, we have to find the branches. We get into each of the branches with catheters, and then we extend with a covered stent. So here's the completion angiogram of a patient that we did in Montreal with good perfusion of the innominate and the carotid. I'm not going to spend too much time on the covered stents. I prefer to use this balloon expandable covered stent, but if you're going to use a balloon expandable covered stent, you have to line it with a self-expanding stent. Another thing I'm proud of is there's only been 2 or 3 cases done here in the United States. The one in the University of Florida, they asked me to come help them there. And in the Mayo Clinic, they asked me to come. And the pictures were so nice from the University of Florida that I wanted to show you this case that we did there. This is a arch branch graft case that they showed me from Florida. They said, can this be done? I was like, at that point, I had done about 8 or 10 if you included my experience in Brazil and Colombia. Not an easy target arteries, different angles to come off. So that's an engineering marvel that they're able to place those branches where they want. But I really believe it has a lot to do more with that nitinol cannula, that pre-curve system that gets all the branches on the greater curve. Here we have the angiogram, and this Adam Beck showed me that once you do that angiogram, if your 3D roadmap, and this is the marvel of technology now, you can do these entire procedures with either a 3D reconstruction, or you can just draw it out, and it makes it so much easier. Your contrast load is much less, your radiation load is much less. It's safer not only for the patient, it's safer for you, it's safer for your staff. Here we've deployed the stent graft. He deployed it very well. Now I'm showing you the branches. So now we've switched from an LAO to an right anterior oblique, and you can see he's coming from the right arm with a catheter and a wire. And you can see the catheter and wire is cannulated, the innominate branch. And then we switch obliques to make sure we're actually in the branch, and then we followed it up with the covered stent. In this particular, it's a custom-made extension made by Cook. On the left carotid, we usually use either an atrium or a Viabon covered stent. There we are deploying the covered stent in the left common. Very important to make sure you're in the right branch, that left branch, and the way to do that sometimes is to play with the obliques. So here we are with the covered stent coming down. Sorry, that's the Amplatzer plug in the left subclavian artery. And this is... He uses a right atrial occlusion balloon instead of rapid pacing, which I think is a nice technique, and that enables us to actually use balloon molding of this proximal stent without having, if you don't have that or if you don't have rapid pacing, what's liable to happen is as soon as you blow up that balloon, that whole arch branch graft is liable to move forward, and you will have lost all the work that you did. And this was the completion angiogram with an excellent result. And there's the 3D reconstruction. So my personal experience out of, I used to obviously have the most in the world. I no longer do that. My colleague and friend Stéphane Hollande in France has that, but I have probably the second or third most because of my combined experience in Canada, the United States, and Brazil and Colombia. And this is what it usually looks like, but I don't think you learn a lot if I just show you my successes. This was a case, I was really worried. I did it with a cardiac surgeon in Winnipeg, Manitoba. He showed me this case, and look at the arch on this. Imagine trying to get these branches to line up there with this arch. So I was pretty concerned about this. We went up, we did the case, and We had an excellent result. And this was case number 3. I can't believe in hindsight that I actually said okay to do that on case number 3. Can you do these patients in dissections? Another cardiac surgeon from Calgary, Alberta, invited me to come do this operation with him. This is a patient with a distal arch aneurysm. As you can see, dissection into the transverse arch, and we did a branch graft. There's the 3D reconstruction, and that case went well. The near misses, this is another case that I did. So this is when you start to become a little overconfident, a little bit too bold, and we saw that someone had put a pretty proximally placed coronary artery bypass graft on their ascending aorta. And I said, well, that's okay. We have a solution to that. We'll just not only treat them with a branch graft, we'll actually put a scallop for that coronary artery bypass graft. Well, I thought that was a good idea at the time, and we did the operation. And I'm pretty generous as far as when I go to do these cases. If the person that I'm working with has some pretty good skills, they will do the entire case, and I'll just do what they can't do or they're not comfortable doing. And he was comfortable deploying the graft, and I swear I watched his deployment. His deployment was perfect. He deployed those branches right underneath the innominate and the left common carotid. Obviously, you can't see where this is deploying. And as soon as he finished deploying, profound ST elevation, profound hypotension, and as you know, it's all happened to all of us in the room. It's interesting how everybody responds. There was mass commotion on the other side of the curtain with anesthesia. People were yelling and screaming, alarms going off. I could hear in my left ear the cardiac surgeon saying something about us murdering this patient. And I grabbed the stent graft and I just gave it a yank. And so all of a sudden, the blood pressure came back, the ST segments disappeared, and everybody was so happy. And what they didn't realize was I yanked it, and now this was partially covering the innominate artery, and this carotid branch was now past the carotid artery. So, you know, again, we went and changed our diapers. We came back in the room, and then you just troubleshoot, and you start thinking about how do we get out of this, and we were able to get out of this. We used the subclavian artery, and this is one thing my mentor in UCSF told me: never close off the subclavian artery, never burn that bridge. And so we went from the subclavian artery into the common carotid branch, and it made it a subclavian to carotid bypass instead of a carotid subclavian bypass, and we got out of it. Stéphane Hollande has reported, there was 4 of us who combined our results, the 30-day mortality rate, and these are high-risk patients that the cardiac surgeons do not want to do with an open repair. 13%, not bad. Technical success, 84%. No aneurysm-related death at follow-up of 12 months. One disturbing thing was the stroke, 16%. That was alarming to us. But interestingly, later on, we did this, again, we looked later on at it. We looked at the early experience versus the late experience, and it was clear. The stroke rate got better. The technical success got better. And I think it makes sense. The more you do, the better you get. Anatomical criteria, I'm not going to spend too much time on this, except to say when you go away from what really should be the anatomical criteria, you have failure. And so I want to spend a little bit of time talking to you about failure. So after my first 4, again, overconfidence, thinking you have this problem licked, start overthinking and say, wow, you know, maybe we shouldn't put the branches like this. Maybe we should put the branches like this, because if I was a catheter and a wire, I might make it an easier time coming into these branches. What happened was, when we did it that way, technically successful, but on the post-operative CT, that carotid stent was pinched off. So I actually had to come back and put a balloon expandable stent and rectify it. Luckily, he didn't have a stroke. This one is one of those cases, you know, I agree with Dr. Eisenhower, you know, and if for any young people in this room, you know, complications, it's the nature of our business, but if you don't learn from your complications, you're really doing a disservice to not only yourself, but to that patient. There's a reason for everything, and you really have to learn from your complications. This is a pretty extreme case. tortuosity, thoracoabdominal aneurysm, an arch aneurysm. He had a previous fem-fem, unilateral iliac occlusion. Was I right to take this on? I don't know. What this did show me is that those branches lined up perfectly with the arch, and I had a technically successful operation, despite having my issues during the operation. Close your eyes, Robert. You may not want to... watch this. So this is two Buddy Lunderquist wires for those of you who are familiar with the thoracoabdominal aorta. Thoracoabdominal aorta should not look anything like what you're seeing here. And so rest assured, I've also sped up this video. This took a while to get up. So we were successful in this graft, with this, getting the graft up. We excluded the aneurysm, and this patient woke up and they were only moving one extremity. And so he died shortly after that. So I had probably pushed clot into his spinal vessels. I probably pushed clot into one of his carotid arteries. But it's a good thing to learn. With extreme anatomy comes extreme complications, so be careful. Again, let's talk about the present. So the bad news in the United States is in order to do those kind of operations, you need an investigational device exemption or you need to do a clinical trial. The good news is that we are now, the FDA is better at letting us do clinical trials. There is hope. We are now we have two side branch devices under clinical trial. We at OHSU are part of the Gore side branch device, but there's other ones, the Medtronic single branch graft. It's called a volcano branch. It's a branch graft at the end of the day. You can call it what you want. It's a short volcano, and it's made for the subclavian artery with a dedicated branch stent made specifically for this purpose. And I'm not going to go too much detail into the delivery system, except to say this can have pretty good results, even in a tight arch. And here you see the completion with good perfusion of the subclavian artery, exclusion of the aneurysm sac. There's the 1 month, 6 months, and 1 year post-op. So this trial had some trouble, mainly because of access issues that they stopped. They have reinstated the trial. It's going to be starting back in September, so we look forward to that. And if this shows good promise and gets approved, then, you know, we'll be putting in branch grafts in the United States. The next one is the Gore side branch trial. That's the one we're involved in at OHSU. Same sort of principle with the branch, but this one has a retrograde branch. So flow is coming through here, then back up the branch, up into the subclavian artery, and then you have the option to put an aortic extender if you need to. And there's no reason, and they are doing this in different arms. There is a zone 2 arm for the left subclavian, a zone 1 for the carotid, and even a zone 0. And good for the FDA for going ahead and allowing them to do this zone 0. So we all await the results of this. The zone 2 is filling up fast. It's these ones that are going to have trouble recruiting patients. And again, I wonder, are we going to have the same problems with stroke that we saw early on when I showed you those ones that we were flossing the innominate artery? Are we going to see vertebral artery strokes with that left subclavian artery? I don't know. So I talked to you about the past, present, and future. The Cook arch branch graft was in all three, really, past, present, and future, and continues to be. They are talking more and more. The one thing that they've seen is when we looked at all our global experience, we only really used 2 or 3 different sizes of the branch grafts. So that actually bodes well for actually getting a clinical trial in the United States. And there's other grafts too. The Bolton relay, single and dual tunnel system, again, is made for arch branch technology, and the worldwide experience there is promising as well. So, future, a lot of people are working with laser cut fenestrations. They're deploying these grafts, getting into the, sometimes doing a femoral to carotid bypass, and then getting into each of these holes and making holes with lasers and then extending with a cover stent. I personally would like to see a commercially made graft that has fenestrations that are specifically made for that purpose rather than using homemade laser fenestrations, because I really think you're violating the graft, and those are going to work short term, and you're going to pat yourself on the back, and then when they come in ruptured in midterm, we're going to have everybody on their case. So I really think the FDA has done a good job of reining that stuff in. You're not supposed to be doing physician-modified grafts unless you have approval from the FDA. The holy grail is the ascending aorta, not so much for the ascending aortic aneurysm. Everybody wants an ascending aortic device for type A dissection, and I don't think it's too far off. Is there a need for this? I think there is. Roy Greenberg, rests in peace, was kind enough to give me these slides before he died. He was at the Cleveland Clinic, a true pioneer, and he was the first to treat an ascending aortic aneurysm with a custom-made graft, and he showed that you could do it. But the FDA, rightly so, has been very tight on letting any companies develop these without having a proper trial, without having the right people doing these cases. We thought we had the right device with Cook's Ascend device. They put it in a couple of patients in Europe. I don't know why the reason this has not progressed, but it doesn't look like this device in its current iteration will ever go to market. This is an interesting device from Israel. I actually put one of these devices in Canada, complete disruptor. So I didn't have any good pictures to show you, but I have this from a model. You actually put this device up into the innominate and deploy it from the innominate down into the descending thoracic, and then you have a fenestration here for the left carotid, and the final piece is an ascending aortic module. Very different than the branch grafts that I've showed you. The problem is there's no way that this company, a small company, is going to be able to afford to do a trial in the United States. So we'll have to wait and see what the future holds in Europe and Asia for the Nexus device. I did a few branch grafts with carotid protection, so I can do carotid stenting, so I know how to use filter wires, and I was shocked the 2 or 3 times that I did this. It's really awkward to put these filter wires up here when you have an open cut down, but look at the junk that shows up in some of these filter wires. And so now that 16 and that 25% stroke rate kind of makes sense, doesn't it? So we need to get better devices. We need to figure out better ways to prevent stroke. And I'm going to leave you with this last patient. We were not able to do a branched arch graft in this patient, but I think this highlights the need for good collaboration between vascular surgeons and cardiac surgeons. I think this highlights the need to think out of the box. This is a Loeys-Dietz patient. I'm not going to go into too much detail except to tell you Loeys-Dietz is a connective tissue disorder. Most of these patients die during their childhood from aneurysmal disease. This is a patient who had their ascending aorta repaired by the Stanford group, ended up in my clinic just to be followed, and 6 months later started showing up with an increasing aortic diameter and this crazy spine pain that I think in hindsight was probably a symptomatic aneurysm. Endovascular repair is a bad idea in aortopathy patients. You need to figure out a way to treat these open. They should only be used as a bailout because their connective tissue disease, it's just a time bomb. The stent graft will fail unless you land the stent graft in a synthetic graft. So this is the patient's anatomy, axial on the left, coronals on the right. Large aneurysm, approximately in the mid-thoracic, going all the way down into his thoracoabdominal aorta. Into his iliac arteries. Thin guy, and just a really wonderful human being, and I'll tell you a little bit about him in a few minutes. But so I thought, easy plan, right? Open thoracoabdominal under circ arrest. He's a Loeys-Dietz patient. He can't have an endovascular stent graft. One thing you may not have picked up, because when I had the cardiac surgeon have a look at them, they came back to me and they said, have you seen his lungs? And of course, like vascular surgeons, we concentrate on the aorta. And have a look at his lungs on this. So he doesn't have much of a lung here. It's all bullae, which is one of the hallmarks of Loeys-Dietz. He has a little bit of parenchyma and some morbulae on the right. So no one was keen on doing an open thoracoabdominal aneurysm in this patient. They felt this guy would never come off the ventilator. So then I had this great idea with one of the cardiac surgeons. We'll do a debranching. We'll have our cardiac surgeons debranch the ascending graft, debranch the supraaortic vessels, and then we'll just do a T-bar of the aortic as a first stage. And then I'll bring him back and I'll replace his abdominal aorta with a synthetic. And then the last stage, we'll just join it all up with a stent graft because I'm landing in synthetic proximally and I'm landing distally. Then we got the thoracic surgeon involved because we were concerned about, doing a sternotomy. Can you just be around so we can deal with these lungs? And he said, you're crazy to do even a sternotomy in this patient. This guy will never get off a ventilator. So now we have some pretty important people saying you shouldn't either do you can't do a thoracoabdominal, you can't do a sternotomy. So desperate times call for desperate measures. I hate this operation, this snorkel chimney graft, especially in the ascending aorta. I think most times you have endoleaks, especially when you increase more than one snorkel. But I thought in this particular case, maybe it's worth it. So we took this guy to the OR. He had a general anesthetic. I did a carotid bypass, a carotid subclavian bypass, and then through his carotid I came down here with a covered stent. You can see the Viabond covered stent here. And then I came from his groin and I put a thoracic stent graft right beside that. Keep in mind, we're all landing in the ascending graft, so we're not violating any principles. Again, important to do intravascular ultrasound. We deployed the stent graft, had a problem with a coarct again, but we just used a Palmet stent to correct that. Now, there's his radiograph showing the Palmet stent. Everything looks great. Here's his CT scan. Have a look at his I want you to look closely here at his innominate stent, and look what happens at his innominate stent as you get closer to the valve. I'm not sure if you saw that. Okay, there it is. Look what happens to this innominate stent as you get closer to the valve. Pancakes out. So keep in mind that's perfusing his carotid bypass, his right side of the vein, his carotid subclavian bypass. So that's a problem. He did not do well after the infrarenal aneurysm repair from a respiratory point of view. And this is, again, you learn from your patients, and this guy was a survivor. Most people cannot tolerate BiPAP for more than 24 or 48 hours. This guy tolerated BiPAP for almost 2 weeks. He was on BiPAP, and it was amazing. And he got through it, and he got off it, and we were able to bring him back, and under local anesthetic of the neck, through a redo, I was able to stent that open, and then, as you can see here, everything looks good. And now we've finished the next piece. I'll show that again. I've extended from his proximal stent graft, and I've landed in the dacron. I debranched all his visceral vessels. And then the last thing I did was close off his subclavian artery. You could see we had a leak through the subclavian artery, coiled it, and the guy did well. So it's nice to end the talk like this after those kind of complications that I showed you with a nice picture of Mount Hood and a nice successful case once in a while. It happens. So thank you very much again for giving me the opportunity to speak to all of you.
So before we open it for questions to all the speakers, we want to make a little presentation here, and we would like to call the daughter of Dr. Kantovitz, Dr. Nikki Kantovitz, to come up. So, Nikki, you are actually doing something on behalf of your father, and of course we're all big admirers, and we appreciate his pioneering work and everything he has done, and Maimonides Medical Center will forever be grateful for what he has done here in this hospital. So, on behalf of Maimonides Medical Center, recognition of 50 years of the anniversary of the transplant, but all the research work that he has done, we would like to give you this plaque in recognition.
Thank you very much. And I'd like to thank both of you. I think that to everybody who was involved in organizing this program this morning, and to all the speakers, I thought it was a great program. It was very thoughtfully done, well organized, and very, very informative. And I am sure that if my dad was here to see all of this and hear all of this today, that he would be feel very gratified that Maimonides has carried on a tradition of excellence and hard work and first-class work. And so congratulations to the whole Maimonides team for everything that you have continued to do, and I'm sure will do in the future.
Thank you. So, the plaque reads, Maimonides Medical Center is proud to acknowledge Dr. Adrian Kantovitz in honor of his legacy of having performed the first heart transplant in the United States in 1967, celebrating 50 years, 1967 to 2017. It is through accomplishment, that's a quote, it is through accomplishment that man makes his contribution, and contribution is life's greatest reward. That's by John Portland. Thank you.
Thank you.
So we would like to have the speakers actually come forward, so if people want to ask questions,
And by the way, I should tell you that when Dr. Kantrowitz was interviewed one time, he was asked, when did he know he wanted to be a heart surgeon? And his answer was, my mother told me I always wanted to be a heart surgeon.
Any questions?
I actually have a question I want to start with. Okay. Dr. Lima, you were speaking about how to, first of all, you were speaking about size discrepancy in and the results of heart transplantation. And a question for that was, is anybody still doing piggyback heart transplants?
Not really, not to my knowledge.
But maybe you could tell them what those are.
Piggyback, like heterotopic, you mean?
Well, yes, exactly. So leaving the...
So what Dr. Ribakov is referring to is sort of the heterotopic variety of cardiac transplant, where instead of putting it in the orthotopic, position where you're replacing it in the chest, you're actually leaving the native heart in place and sewing it either directly to the heart, which is one way to do it, or, theoretically you could do it to the aorta and IVC, but not real. In my entire career, I think I've seen one case of a young patient that had a heterotopic heart transplant. It was actually done by Cooley, and was having graft failure, a chronic rejection, and we were sort of trying to sort out what in the world we would do, whether we would take, which of the old hearts we would take out, or we would take out both, or just sew a third heart. And I think we arrived at the decision that we would do a third heart. But he was kind of touring around the country getting, 3, 4, 5-second opinions. So.
Interesting. And I have one other question. You know, there's this thing out there, and you were again talking about being able to use more donor hearts, and the people talk about the alternative heart transplant list for people, for recipients who won't really make the grade, maybe too old or other reasons, and for donors that don't really make the grade. And is anybody still using an alternative heart transplant list?
That was popularized at UCLA and at Duke. Unfortunately, heart transplantation is so highly scrutinized by the sort of governing bodies that our outcomes really have to be up to snuff, and there is not an exception offered for, you know, offering, for example, discarded hearts that aren't taken by anybody, and offering to patients that would not otherwise be eligible for transplantation for any variety of reasons. UNOS won't, you know, cut us a break on that. So unfortunately, and it is unfortunate, that we should be able to do that. But I think until some changes occur in these governing bodies, I think most people will be risk averse to undertake those types of things.
Question, Ben?
For Dr. Abraham. Ben Udelman, the co-director of the Aortic Center and director of thoracic aortic surgery, work with Dr. Ree. You know, Dr. Abraham, you pointed out a couple of very interesting things. One was, thank you very much for proving me wrong. I just gave a very nice talk to the fellows, showing them that the last case that you presented should probably never be done except in exceptional circumstances. And I appreciate you showing them exactly what I meant by exceptional circumstances in a low speeds patient. But what I wanted to ask you about is the one area that we can prevent, which is probably the thoracoabdominal aneurysm formation in a status post type B or a residual type B dissection. That's the Achilles heel that probably Dr. Ree and I talk about most, especially when we go out to dinner and have our aortic center directors meetings every 6 weeks or so. The question is what do you think we can do during type A repair that is going to fundamentally change the natural history of the development of a thoracoabdominal? And the second part of that is, in these uncomplicated type Bs, what do you think, or where are we at, and what do you think we should be doing looking forward to try to prevent these thoracoabdominals? Because I don't think that a branch graft for a thoracoabdominal is a better answer than trying to prevent these from developing in the first place.
Yeah, thanks, Ben, for your questions. I don't know if there's an answer for your first question about what we can do to change the natural history. I think we're on the right track because, specifically, I think because the cardiac surgery now is embracing doing these frozen elephant trunks and trying to change the natural history. Even if they don't change the natural history, the nice thing about those frozen elephant trunks is it makes the next operation a lot easier. And I don't know why it's taken so long. I suspect cardiac surgeons are just as stubborn as vascular surgeons. That's why, you know. But now we're starting to see it. And the good thing about it is we have people like you, we have other people who are going to keep track of their results, who are going to start really looking at, is the true lumen and false lumen changing after just the frozen elephant trunk? I think there is good news on the horizon. I think in 2018, the dissection bare metal stent is going to be approved by Cook. So there's theoretically, you could not only throw in that frozen elephant trunk, you could throw in that bare stent all the way down to the thoracic aorta and not worry about paraplegia. And I think those are things that are going to maybe change the natural history. So far, though, things like the STABLE trial have shown that despite in a clinical trial, they put that proximal covered stent in the type B dissections followed by the bare stent, they didn't change the incidence of aneurysmal dilatation. They did improve some malperfusion. So there's still a reason to do it, but I think only time will tell. If you're asking me what is the optimal treatment for an asymptomatic type B aortic dissection, it really depends on a host of variables. It depends on the age. It depends on the degree of false lumen to true lumen ratio. I think it depends on, is there a little bit of dilatation of the proximal thoracic aorta or no dilatation? I think it also depends on whether these patients, as you know, and I'm sure here the population here in Maimonides is not too dissimilar to our population, a lot of these patients may never come back. So you've got to do what the right treatment. And the first knee-jerk thing is to say, oh, if they're not going to come back, we shouldn't treat them with endovascular repair. But how about this? If they're not going to come back, do you think they're really going to take that blood pressure medication? Maybe is an endovascular stent graft protective for that person that's not going to take their blood pressure medication? I don't think we have the right answer.
Role for fenestration early in patients without visceral.
So the question, Dr. Eisenhower, is there a role for fenestration? And basically what that means is cutting the flap, the true lumen, false lumen flap, so that you are now equaling the perfusion, so theoretically your true lumen is not as compressed. I think there's definitely a role for that. There's two problems with that. Technically, it's not the easiest thing to do. And then, I don't know if anybody from industry is here, and I mean no offense to them, but a very smart person in Stanford named Michael Dake, who is probably the most, the authority on dissection, and a surgeon named Ramon Berger have come up with a device specifically to tear that, and perhaps you won't even need to put a stent graft. If you're a company and you have that come to you, is that something you want to support? Because you won't be able to sell another stent graft. So I'll let you take, I'll let you take that and think about that. But my guess is it's not going to happen.
One question, Dr. Eisenhower. When do you think we'll be in the mitral where we are right now at TAVR?
So maybe never, but I think it's going to be a long time. That's the theme of today. Yes, yes, I think it's going to be a long time. Because one of the problems is mitral valve disease doesn't kill you quick. Aortic valve disease does. So the issue is not going to be can you do it technically, it's going to be what the long-term outcomes are. And it's going to be hard to find surrogate endpoints in the mitral space. So I think it's going to be a long, slow slog.
What's your opinion on the mitral clip?
So the mitral clip has a place. It's a good alternative for patients that don't have a good situation for mitral repair. And one very non-scientific way to look at it is to ask a cardiac surgeon or a cardiologist if you developed sudden degenerative mitral regurgitation, what would you have done? Probably 11 out of 10 would say they want their valve repaired.
I agree, yes. Okay. Thank you so much for joining us today. I think it was a very successful day, and have a great day.